Okay. Yeah, good evening, dear teachers and friends. We welcome you once again to our Neuro Club of this month. And we have a very exciting program hosted by the Cosmopolitan Hospital at Trivandrum with a very exciting lineup of speakers, almost of, you could say probably international standards. We have, lived through this very difficult times, hardly catching up with each other face to face, always seeing each other through across a computer screen, and it's with a touch of sadness that we have to start this meeting with a touch of sadness, remembering Gauri Shankar, the zonal manager of uh, this is the person whom we knew very well, who passed away a couple of weeks ago due to COVID. He was just 38 years old, and has been always in the forefront and has helped even in the organization of our Trivandrum Neuro Club meetings many times in the past. Let us just take a moment of silence to remember Gauri Shankar and his contributions to the field of medicine.
Om Shanti.
Thank you very much, everybody. It's my proud privilege to welcome our dear teachers and our friends. All of us are so excited to hear this wonderful program put forward by Cosmopolitan Hospital. And I'm very happy to welcome first Dr. Malini. Dr. Malini Gopinath has had a very, very illustrious academic career, both during her DM Neurology residency at Sri Chitra and also subsequent to that. She is a senior consultant in neurology at Cosmopolitan Hospital and has been continuously retaining that dazzling academic touch. And to present to us, to share with us a fascinating case of paraparesis, may I invite Dr. Malini. At the same time, may I also invite our chairs in neurology, Dr. Praveen Panicker, Dr. Ramshekhar, Menon, Professor MD Nair sir, Professor Abraham Kurvila, who is from a very different time zone. Sir is now at Tucson, Arizona, and may just be able to join us. And Dr. Mini from SAT Hospital. Welcome each and every one of our moderators, and I'm happy to welcome Dr. Malini for the first talk. Dr. Malini, could you please unmute yourself, please?
Hello, Dr. George, am I audible?
Yes, you're very well audible.
Yeah, very good evening to the chairpersons, moderators, teachers, and my colleagues. At the outset, I would like to thank the organizers of Trivandrum Neuro Club, especially Dr. George, for giving us this opportunity. Being the opening batsman of this new chapter of Neuro Club, I would like to draw your attention to an Yorker, which we all will have to face in the coming days. So, shall I start with my case? Shall I?
Sure. Please go ahead.
So I would like to present the case of a 76-year-old gentleman who was a hypothyroid and dyslipidemic who presented with a short history of myalgia and tiredness of 3 days duration, fever and cough of 2 days, with difficulty in getting up from squatting of 1 day duration. He did not have any upper limb fascio-oculobulbar weakness, and on examination, he was febrile with a heart rate of around 102. He had mild tachypnea with bibasal crackles. CNS examination, high mental functions and cranial nerves were normal. Upper limb was completely normal. There was significant lower limb weakness, proximal more than distal, with retained reflexes. Plantar was flexor. Sensory system was normal. ECG was showing sinus tachycardia without any significant STT changes. The counts showed lymphopenia with a normal platelet. Inflammatory markers were elevated. CRP was around 5.8. PCT was 0.23, creatinine was normal, SDOT was elevated, and cardiac enzymes were also elevated. CKMB was around 80. See, since the patient had myalgia with weakness, a CPK was sent which was 9,500. As the CPK was very high, CKMB was repeated in dilution, which was only 8. The rapid antigen and PCR for SARS-CoV-2 were negative. Since the cardiac enzymes were elevated, tachycardia was there and echo was done, which showed diastolic dysfunction grade 1 with a good systolic function. The ultrasound was normal, but CT chest was showing bilateral pleural thickening with fibrotic bands and right lower lobe minimal collapse. So he was admitted under medicine, and next day, when the neurology review was done, he was afebrile, myalgia was better, and power has in fact improved. From 3 power, the lower limb proximal power has improved to 4, and distal was remaining 5. Reflexes were retained. Since he had a paraparesis fever related, a conduction was done. The distal latency was prolonged with a mild reduction in conduction velocity in both the median and ulnar nerves. FVs were normal. Lower limb snaps were absent, but from the upper limb, the peak latency was prolonged. Lower limb, the, the distal latency was mildly prolonged from both the median and ulna, and conduction velocity was also reduced. FPs were normal. So probably a demyelinating sensorimotor polyneuropathy was thought of. CPK was coming down from 9,000, it became 4,000 the next day itself. LDH was a bit elevated with 420, serum ferritin was 244, D-dimer was also elevated to 1400. Since CPK was now increased, the thyroid functions, parathormone, calcium, phosphorus were done, which were normal. There was no myoglobinuria. Vasculitic workup was also negative. So the relatives were discussed regarding the lower limb weakness with a mild demyelinating pattern, and the option of a treatment with IVIG was discussed. Since the patient was improving, the enzymes were coming down, the plan was to follow up the patient clinically and electrophysiologically, and if there is any worsening, to go ahead with further management in the form of IVIG or the like. Next day, again, the patient was improving. He was febrile and became ambulant without support. Reflexes were still retained and the power was also improving. CPK coming down to 2,425, but D-dimer was still elevated, 1,468. So we did a repeat RT-PCR, which came as negative. Since the first RT-PCR was negative, a respiratory panel for the other viruses like influenza, para-influenza, respiratory syncytial CMV was done, which was negative. Other fever workup, scrub, lepto, dengue were negative. CMV serology was also negative, but SARS-CoV serology was showing an IgG index of 18, where more than 1 is positive in our lab, and IgM index of 1.22. In view of the D-dimer rise, the CT pulmonary angiogram was done, which was normal. Lower limb venous Doppler was done, which was normal. And since the patient presented with fever, blood and urine cultures were sent from ER itself, and it came out as sterile. The patient was clinically and laboratory wise improving. On the day 5, he became asymptomatic with normal power. The lymphopenia has also improved. Platelet was throughout the course normal. CRP has come down, PCT has come down, liver enzymes was normal. CPK has also come down to 755. D-dimer was again in that 1,500 range, almost 3 times the upper limit of normal for our lab. And conduction was done, which showed the previous prolongation in distal latency and decrease in conduction velocity was normalized. Since the patient was improving, we plan to continue the observation. So in short, here, gentleman presenting with a short history of fever. So we, in view of the serology, we retook the history, and there was a history of a short febrile illness with cough in December 2020, and he was given the Covishield vaccine on 25th of March. The onset of the symptoms were on 17th of April, and 23 days after vaccination. So we have a self-limiting short febrile illness with features of myocarditis, myositis, demyelination, and increased fibrin degradation products. I would like to have the opinion of the teachers and colleagues regarding this.
Yeah, good case, Malini. Nice worked up.
Thank you, sir.
So it was looking like whether it was a COVID-related situation,
Yes, sir.
but then your RT-PCR was negative.
Twice done, sir, negative here. I was also
Negative.
actually thinking about COVID itself.
Yeah, because it all came with that. And it fits with a combination because of the elevated CPK. There was probability of a myositis, and then there is effect of demyelination in view of the prolonged distal latencies, peak latencies of the sensory, and reduced velocities. What was the F wave status also?
Normal, sir. FS was
F waves were normal. Okay, so
completely.
maybe it was more predominantly distal type of presentation
Yes, sir.
rather than being proximal. And then, so overall, it looks like that. In between, you said about these indexes.
Yes,
What does that mean?
sir. I will
That
be
code?
that is the serology of the COVID after a natural infection and after a vaccination. There's a difference. So
Yeah.
we had an IgM
So
mildly elevated and IgG which was significantly elevated.
yeah. So what does that translate into?
It shows that most likely patient who had a COVID infection had a vaccination showing a more IgG response rather than an IgM response. I'll be coming to that later, sir.
Okay. Okay. So that point needs some real good inputs from ID group or somebody
Yes, sir.
because that means the time profile of the cases this Covishield was given, so you attribute it to the vaccination or you attribute to the natural infection due to COVID.
Yes, that is the actually the main purpose of the case was whether we will attribute the case to the vaccine or the virus.
Since the RT-PCR is negative on 2 occasions,
Yeah,
so there is no active infection, I think so.
sir.
And then what is the CT thorax showed? Did
See,
it show any
no,
ground glass appearance or anything?
no, sir, no acute lesions like ground glassing,
Okay, okay,
no showing
okay.
predominantly
So
fibrosis.
this could be a post-Covishield kind of a thing which actually has improved spontaneously. Did you give any steroids or anything?
Sir, actually, I didn't start anything. We just symptomatic management. Initially, we discussed about IVIG and all because of the demyelination. Instead of steroid, I was thinking about IVIG, but clinically
Hmm.
the patient was improving. And since the patient was improving, I didn't start on IVIG. But the
Hmm.
D dimer was significantly elevated. Even post discharge, the D dimer has increased to around 2000, even though there was no evidence of any thrombotic tendency. So actually, I
Hmm.
started on rivaroxaban 10 milligram OD as part of the rising D dimer, and patient has
Yeah, yeah.
any
So one last question, Dr. Malini. What was the internist's opinion on the case?
the ID people I discussed with two of the ID specialists in Trivandrum, sir. They were also more in favor of a vaccine-induced hyperimmune response.
Yeah. Just the other day, we had one case we were discussing post Covishield. This gentleman, young fellow, developed a massive venous thrombosis in the brain and presenting a status and that kind of a thrombotic kind of a complication. There are issues which are coming in, but the incidence is very, very low. If you take the overall picture, so these are coming as stray reports.
Yeah, sir, I
Okay.
was going to tell
Is
about
is
all those things. Shall I
Yeah,
go to the second part?
yeah, yeah. Please.
is there a time frame wherein these complications are known to occur after the vaccination?
Yeah, it is usually reported. Some of the, especially myocarditis, is reported in the first 3 to 4 days, but other events are reported at 3 weeks. Shall I go to the next part where
Yeah,
everything
yeah, yeah.
is
Please, please,
been? Shall I start?
please carry on. Have we lost Dr. Malini?
Can you hear?
Now we can hear.
Okay, sir. I will start now. Is my slide seen?
Yes, we can see.
You can see. Okay. So coming to how will we find that whether the vaccine or the virus was responsible for our case? So in short, there was a probable COVID infection in December. The vaccine first dose was taken on 25th of March. 17th April, we have an acute febrile illness with myalgia, tachycardia with elevated cardiac enzymes, painful paraparesis and a demyelination, which had a self-limiting course over 1 week. So is it the vaccine or the virus? So let me take the virus first. First point is, was the infection in December COVID? Yes, most likely, because the history was showing fever with cough. CT was showing telltale evidence of infection in the past with fibrosis and pleural thickening. And the serology, coming to serology, this was our serology. And IgM was around 1.22 and IgG was around 18. Both more than one index is positive in our lab, where we are doing the enzyme linked fluorescent assay. When you take the antibody response, immediately after the vaccination, after the infection, after 3 days of infection, usually the IgM and IgG both start rising simultaneously. IgM reaches a peak around 2 weeks, and after 4 weeks, it slowly comes back to normal around 6 weeks, not very definite. IgG at the same time starts rising and peaks around 3 to 4 weeks, remains like that around 6 to 8 weeks. Exact the duration for which IgG remains, we don't know. And after vaccination, it has been shown that past history of COVID infection resulted in a significantly greater antibody response to vaccine. So what we have here is an IgG of about 18. In our lab, we had done almost 150 cases, and we have seen that immediately after a infection, our values were around 10 to 12 index. And after vaccination, we have seen, especially after second dose of Covishield, we have seen cases where the range was around 18 to 20. Here we have a case where the IgM is mildly elevated and IgG is around 18, which is more in favor of a vaccine-induced IgM rise and IgG, which is contributed by the previous COVID infection. Second question is it part of the first COVID infection which occurred in December? Is it a post-COVID syndrome? Unlikely, because according to the NICE definition, usually the signs and symptoms develop after the infection and it continue for more than 12 weeks and are not explained by an alternative diagnosis. It may not be in continuous with the symptom, but should develop usually within 12 weeks. Here the patient had the infection in December. Symptoms started in April. He was completely asymptomatic between. So the third question is the second infection by a COVID virus itself. Repeatedly, the PCR was negative and IgM was around 1.8, which is not so high for a patient with recent COVID infection. So is it the vaccine that is responsible? So let us just think about the molecular mimicry of various induced autoimmunity in vaccines. In genetically susceptible individuals, vaccine may induce immune cross-reactivity. We have very good examples of H1N1 vaccine and HPV. So before going into our case, let me just take you through a few reports on vaccine-induced autoimmune phenomenon with regard to SARS-CoV. There has been a editorial in NEJM June 2021, where we have vaccine-induced thrombotic thrombocytopenia, just like Nair has described. Usually it is seen 5 to 24 days after the vaccination. Here, adenoviral vector vaccines were used and healthy women were affected with thrombosis at unusual sites like CVT, so has told, portal veins, splanchnic vein, hepatic veins, etc. The platelet count was very low in those cases, 20,000 to 30,000 with a high D dimer and low fibrinogen. We had a high D dimer, but our platelet was normal throughout. And the mortality was a bit high in these patients. High level of antibody to platelet factor 4 was implicated in this, and the treatment was IVIG and high dose steroid. Another group of autoimmune conditions which have been recently reported is myocarditis and pericarditis. Recently, the CDC has updated a COVID-19 vaccine safety guidelines, where the reports of myocarditis and pericarditis in US, especially in vaccinated people between 12 to 30 years, have been combined. The median onset of symptoms was around 3 to 4 days after the second dose. Mainly, males were more affected, but generally the outcome was good. Just a small case series among healthy adult males, which came in Pediatrics Journal. Here, after the second dose, many of the patients presented with fever and chest pain, and all the patients had elevated trough. Echo was majority patients normal, and MRI was showing features of myocarditis. The point I would like to highlight is, among the 7 patients, 3 were treated only with NSAID. Immunomodulators were not given, and the patient recovered fully. And there are reports of autoimmune hepatitis also coming after COVID-19 vaccine. One of the case reports in Journal of Hepatology has mentioned about a 35-year-old Caucasian female who had hepatitis after vaccination. It started around 1 week after the vaccine. And I had gone through the literature and got only one case report of myositis related to COVID-19 vaccine, but it is different from our case in that it is at the site of injection. But in that case also, I think autoimmune etiology is important. That's why I'm presenting that. A 56-year-old non-diabetic who did not have a previous infection presented with left upper arm pain 8 days after the second dose of vaccine. There were no systemic symptoms, and there was tenderness with uh, weakness of shoulder on the same side of vaccination. CK was elevated, CPK was elevated, and urine analysis excluded myoglobinuria. This is the MRI. T2 was showing hyperintensity in the deltoid with contrast enhancement. The patient was managed with just rest, cryotherapy, compression, and NSAID, and the symptoms completely resolved in 6 weeks. But the MRI was showing the symptoms almost till 2 months. So the authors have suggested that because of the temporal link between the symptom and vaccine and the reversible toxicity, they have implicated the vaccine as cause for the myositis. And in addition to the muscle injury, the toxic myopathy may be a reason for the the commonly reported severe vaccination site pain in a majority of the vaccinated individuals. So coming back to our case, we have some points in our favor, mainly the temporal association with the vaccine, the clinical picture of pain with proximal weakness and CPK elevation, and the serology favoring a vaccine after a COVID infection, which must have triggered an increased immune response to the vaccine. But do we have any points against? Actually, one of the points which I thought was there was no treatment and the patient improved, but recently all the pericarditis and myocarditis reports are also showing that patient is improving without any immunosuppressants, and so far no case has been reported. So we have a vaccine-associated myositis, probable myocarditis, reversible demyelination, and a D-dimer elevation without any thrombotic events. So I would like to conclude hoping for a safer vaccine in terms of immune cross-reactivity in the future. Thank you.
Thank you so much, Dr. Malini, for that fascinating case. May I request our moderators to please give their views and comments on this presentation, please?
Madam, just one little doubt. I want to ask: could the statin, could that have contributed to the muscle injury in this case?
Yeah, patient was on 10 milligram statin for the past 2 years, and the statin was continued on 10 milligram. It was not reduced or stopped. The CPK from 9,000 came to 4,000 the next day itself without stopping statin. Usually in statin-induced myopathy, when we stop statin, the CPK will come down, and even in autoimmune cases, it may increase even after stopping statin. So, seeing the temporal profile and the course, it is unlikely to be statin-induced myopathy. And we have
And
autoimmune disease in the form of myocarditis and demyelination, which got corrected. So I would favor autoimmune myositis in this case.
Dr. Malini, one query. How do you explain that the upper limbs were spared completely?
Conduction was showing upper limb involvement. Clinically, I did not get any weakness, and the reflexes were also preserved, sir. I am also not able to explain the entire clinical picture, but
Also, the temporal profile of so rapidly improvement also makes us wonder what are we dealing with it.
Yes, sir. That improvement was very dramatic without much treatment, to be frank. I didn't start any steroids because first day it was more like a fever with myalgia. So second day only I reviewed the case. I saw the CPK, and seeing that it has come down, clinically patient has improved. We didn't go ahead with steroid. We discussed the case with the bystander and thought we will wait and see whether the patient is having any worsening, then we will go for immunosuppression. That was my thought at that time.
Yeah, that is a good point Dr. Satish has raised regarding the sparing of the upper limbs. So the one last thing is the reflexes were preserved or they were absent?
Preserved, sir. Even the first day it was preserved, it was preserved throughout. That is why initially itself, even though demyelination was there in the conduction, sir, in the upper limb conduction was showing demyelination. Only clinically I didn't get any weakness.
So that may, because there is a variant of GBS which has got what is called as a hyperreflexic type of variation, in which this can be more regional, you know, and then you always confuse whether there is a myelitis in addition because the reflexes are preserved. But then when you do the imaging, there is no chord change or nothing. And on the contrary, when you do the NCV, you find distal latencies are greatly prolonged. So here the pathology is actually more distal. And sometimes you may get reversible conduction block in these group of patients. And this has been, I think, discussed from the Japanese group. And they make a rapid recovery, you know, they make a rapid recovery. And some group, if it's more proximal, affecting the proximal roots, affecting, then they turn into more, what you call, more progressive variants, you know, like they develop more of a acute axonal kind of syndrome. So the whole literature of GBS itself is quite complicated, and it is essentially based on repeat conductions. You know, you can only sort out the real pathology on doing repeat conduction and seeing what is persisting and what is the overall. So may the upper limb you can repeat and see, you know, whether they have improved.
After 4 days and down to
Yeah.
now.
And how was the lower limb conductions?
Lower limb conductions are pickup was having a low amplitude, but proximally it was normal, and the tibial was also normal, lower limit of normal, to be frank. Sir, another thing I would like to discuss is this patient, if they are asking for a second dose of vaccine, which is due now. So, in this setting, will you advocate the patient to take the second dose? Because all the reports are so far showing all majority of the autoimmune phenomenon occurs after the second dose of vaccine. Here, should we go ahead with the second dose or should we withhold a second dose?
Yeah, that's a really tricky one, because you have already, there is evidence, if you are going based on the vaccine hypothesis, he's already been sensitized, you know. So I don't know whether it will trigger a more hyper kind of response. So I think you will have to ask the vaccine expert, you know, and you know the whole kind of literature which is happening. Some people saying something, some people saying other things. So I think you'll have to go by the consensus and the prevailing, what is the status of the, because the ICMR and all these people are involved. So what they are doing, what in such situations, I think you may have to get a real good opinion.
Yes, sir.
When it is due actually.
Yeah.
Now that the duration is actually, they are trying to reduce it. Earlier they said it can be taken at the end of 84 days, the second one. Now they are trying to cut it down to 2 months. So you may have to take a decision whether, but on the overall, your patient was really lucky with
Yes,
so many complications, and without any much of morbidity, he came around. It's really good that he has recovered. That you can only say good things only.
sir.
But it was a tough case to really dissect it out with so many organ systems getting involved.
The patient, and I was also lucky because the patient improved. Second,
Yeah.
I have discussed with many of the infective disease specialists. There is no consensus regarding whether to go ahead with the next vaccine or not. It is due 3 months. That is in July. It will be coming.
Ali, can I add one thing?
Yes, madam.
Because our patients, children are not getting vaccinated, and we do see most of the children remain asymptomatic after a COVID infection. So right now in our ward, we have a 6-year-old boy who had his RT-PCR positive after traveling to Delhi in March 22nd, in April 22nd actually, and in May 12th, he presented to us with an acute, hyperacute onset of a asymmetric quadriparesis, and we evaluated him. His antibodies were in the range of 1,000 at that time. We can only do IgG antibodies right now. And the second thing was that his MOG antibody also came positive, and he had a cervical long cord involvement. And so here there was no vaccine as the culprit. And many patients with the pediatric, our experience is that after the acute onset of COVID, they present with what is called as a multisystem inflammatory syndrome, where all these parameters can be elevated, D-dimer, all those things are elevated. And during that phase, some of them do develop neurological complications. We had one patient with sinus venous thrombosis. We had another patient with optic neuritis, facial nerve palsy, so stroke-like episodes. So we don't know whether these are just COVID is an innocent bystander there, and these patients are getting various sorts of neurological manifestation. But actually, over the last 2 months, after the second wave has started, we have started seeing increased number of such cases. So we don't know whether this is a COVID infection per se, which is causing neurological complications. So not only the vaccine, but the COVID infection itself can cause more damage to patients than probably the vaccines.
I completely agree with you. I was also thinking like that. Whether is it some equivalent of the multi-system inflammatory response, which is initiated by the vaccine in this case, because I think it is vaccine because of the IgG response. Depending upon the various antibody tests, madam, the ranges are varying. There is no consensus. I checked, and the values I compared with just our own lab, because in international guide, some of the recommendations they are telling it is 50. In some of the values they are putting it as 1,000. So when we standardize with our own lab, these are the values we got.
It depends upon the methodology also. They are using immunofluorescent as well as the electrochemical methods, and also values depend upon the method they use.
Malini, one question I want to ask you. I was also thinking whether it could be a multi-inflammatory syndrome, because I think it is very important. If it is multi-inflammatory syndrome, I think, and not due to the vaccine, you can certainly give the second dose of the vaccine, which I think is very important, because I think with these comorbidities and all, I think he should not develop a reinfection with COVID, especially in the coming waves, the third wave and other things. So I think it is very important to be, I was also thinking whether it was multi-inflammatory syndrome. I think multi-inflammatory syndrome is certainly more common in children. And I think it can be even fatal in children. So, but this could still be a multi-inflammatory syndrome and not necessarily, maybe I think triggered by the vaccine. So I think it is very crucial whether you should give the second dose.
Multi-inflammatory syndrome in adults, which has been reported following COVID infection, but regarding vaccine-induced, there have been no reports and no criteria so far.
So which means we can give the second dose of the vaccine. Is that what you're saying?
No, I think it will be better to withhold a second vaccine for the time being, because it may trigger another cascade of immune responses. That is my personal opinion. There was no consensus even after discussing with various experts in the field. So
thank you very much, Dr. Malini. I'm sorry to interrupt because Dr. Abu has just requested he has a case to be done next. Thank you so much for that very fascinating presentation. I think we have enough meat in the matter to discuss throughout the night, and we must catch up on this discussion, leaving it incomplete now. Thank you very much on behalf of everybody. Thank you to all our moderators. Next, may I invite Dr. Abu Madan. Keyhole surgery is a very exciting topic, both for the layman and for the neurosurgeon. And Abu is here to tell us not just about keyhole surgery, but also daycare keyhole surgery. Dr. Abu Madan, Senior Consultant in Neurosurgery from Cosmopolitan Hospital.
I am audible?
Yes, Abu, we can hear you.
Yeah, thank you. So, respected seniors and my dear friends, a very good evening to all of you. First of all, I must thank
Abu, there's a little bit of an echo. Can you try without the headphone?
Okay. Now is it okay? So now is it okay?
Yeah, it's better, much better.
So,
do you have two equipments on, two electronic equipments on in the same room?
Yes. Yeah, sir. Actually, I'm in the hospital.
If you have logged in with the phone also, probably you can log off one.
Yeah. No, I just using my
I think, Abu, if you've got a speaker on, I think you should switch off that speaker.
Yeah, I think it's fine, Abu. Please go ahead.
Okay. Now it's okay, sir?
Yeah, it's fine. Perfect.
You don't know. Okay, sir. I will try, sir. So now it's okay?
Yeah, it looks okay.
Okay. So yeah, but your screen share. So, respected seniors and my dear friends, a very good evening to all of you. First of all, I'm thanking Trivandrum Neuro Club, especially Joseph, for giving us this opportunity. So, my topic for today is minimum invasive posterior cervical foraminectomy, which we usually do nowadays as a daycare procedure. So, to start with, posterior cervical foraminectomy is actually a safe and very effective procedure that is usually used for the treatment of problems that are related to the foramen of the cervical region. It's got good success rate of almost 90 to 98%. but it's not out of complication rate. The complication which usually happens is
5 minutes. 5 minutes. 5 minutes.
Okay, and the recurrence rate has been recorded up to 5 to 10%. Now, this procedure was usually done in the late 1950s as the most common approaches, just like a lumbar disc disease. But as Clover sir has introduced the technique of anterior approach, which was much easier as time passed away. So the posterior cervical frontal has gained very much of, has actually lagged a lot. Now, the most important problems with the anterior approach are recurrent laryngeal palsy, especially with the non-recurrent laryngeal nerve, and other problems like dysphagia, speech disturbance, esophageal injury, and airway compromise, and injury to the Werner cells. Now, one more problem with the anterior cervical approach will be a segmental adjacent segment disease, as well as altering the biomechanics of the cervical spine that may result from discectomy and fusion. Now, the best thing of a posterior cervical approach is that it is easily used for the treatment of anything that is related to the foramen of the cervical region. And the most important thing is it offers a direct visualization of the exiting nerve roots and avoid fusion. Now, even though this is done as a daycare procedure, there are certain hurdles among this. The first important thing is venous bleeding, especially from the epidural veins. Now, this is usually being controlled with the help of hemostatic agents, or if you have time, you can just keep a patty and wait for some time. But the most problem that was faced during earlier time of posterior cervical foramen in the open approach was that, which has resulted in because of this significant muscle dissection, there were an increase in postoperative pain and muscle spasm as well as in hospital stay. So like a lumbar open discectomy, open cervical posterior cervical foramen also had problems like muscle deterioration because of retraction injury, which compromised the biomechanical stability and also negative long-term effects because of the dissection of the muscles of the posterior spine. Now, endoscopic microendoscopic foramenotomy developed by Rotter to address the root was an excellent procedure which actually avoided all the collateral damages. And this is just an example to show that this is ideally a good case to undergo posterior cervical foramenotomy. You can see that the disc is actually at the foramen and the lateral part, and it's an acute disc, so that this can be easily taken out through a posterior cervical approach. Now, the basic contraindications which we now consider are mainly instability and the location of the disc, which is mostly central, and any evidence of spinal cord injury. Now, as usual for any posterior approaches, the positioning is like just in the prone position or even in the semi-sitting position, and the shoulder should be tapped so that you can get a good view of the region where the X-ray should be exposed. And we routinely don't use SSCP and electromyography, and Foley's are all avoided. Now, localization is just you place a 18 gauge spinal needle, identify the level, and then with the help of serial dilators, you inserted the dilators, and then the final tube is fixed. The incision is placed just to 1.5 to 2 centimeters away from the spinous process. This actually looks like how the tubes are all placed. There's one difference, like usually the handle of the tube will be placed medially so that it will be easier for us to manipulate during surgery. Now, the surgical technique is actually in the previous time, we usually go through interlaminar approach and then go to the area of the foramen by cutting off the facet. But now we use directly high-speed drills to directly open up the facet region without disrupting the interlaminar space. Now, this is how you can see the medial and lateral part and the cranial and caudal part. And this happens after you have exposed your laminar foramenotomy. This is a pictorial representation to show how this how the final view comes like. And then in certain cases where there is not much of space, we may have to go to drill the supromedial part of the inferior pedicle so that we can access the disc space. Now, the most important things which we always take care of is to gently retract the nerve superiorly. The most important thing that all of us usually faces is the excessive bleeding from the epidural space, which can be easily controlled by identifying the superior and inferior pedicle. And from the pedicle, you go down to the root by coagulating on a low power so that the epidural veins get compressed. Get coagulated. And then you can see the disc space clearly. In case you don't have a good approach to the disc, you can remove the drill off the supromedial part of the pedicle and then access the disc space. Maybe if it is a contenders, you have to just open up the posterior longitudinal ligament and use reverse curetors or micropituitary rongers or any to remove the for an extruded component. So this is how you can see that the pictorial representation where the root has been uplifted and to the inferior part of the root we usually take off the extruded disc. Now, postoperatively, this is how an incision looks like. Postoperatively, there are no Philadelphia collars, no collars are used. And this is a short video just to see, show. Actually, on the right side of what you see is the middle part. So you drill, you complete the lamina foraminotomy, you excise the livinum flavum, you can see that the epidural veins are bleeding. So we usually use hemostatic agents or even pack the region for a pretty little bit nowadays our technique is just to identify the superior and inferior pedicle, and from the pedicle we gently retract. You can see that a small incision is made. And with the help of ankle curettes. Here's another video where again the same principles of laminar foraminotomy are done. You can see that through the inferior part, in this case we actually didn't made an incision.
Abu.
Sir, I'm audible?
Now audible, audible.
The help of an instruments, gently retracting the root, the extruded disc material is coming out nicely. And at the end of the procedure, you can see that the root will be pulsatile and also there has been good decompression of the root. It is not always necessary to remove the disc as a single piece. You can also remove it in piecemeal. But if it is an acute case, it always comes in a single piece. So this is the procedure which we usually done some 2 to 3 years back. We start from the medial aspect of the lamina, but nowadays we directly open the facet joint. We don't take the lamina. So our experiences of the last 6 years, we had 29 cases. Actually, being a cervical disc disease being so common, you can see that the rate of posterior cervical foraminotomy is very, very less. So among these C5-6 has got the most important numbers, and 2 levels were done in one case. An accidental durotomy happened only in one case. It was only a minor leak because we are using high magnification. So it was just a needle puncture that happened, and was just managed with the help of a fat. And only one person had to undergo an SCDF after a period of 2 years. Now, the results comparing open and minimal invasive, both the long-term results are almost same, and there is no statistical significance among the both. Now, these are all papers bearing the effectiveness of open and minimal invasive. But as we know that the amount of collateral damage is always less with minimal invasive approach. Now, the long-term results with minimal invasive approach are also very good as open approach also. Because whether it be open approach or minimal invasive approach, the end goal remains always the same. Now, to conclude, MIST technique was developed as an alternative to traditional approaches, which actually reduces the post-operative neck pain spasm and gives very good relief for the patient. There are multiple studies to have just shown that the overall length of hospital stay is less, there is faster recovery and decreased blood flow as compared to an open surgery with MIST. So our message is nowadays posterior cervical furanotomy is done as a daycare procedure. The patient will be admitted in the morning and will be discharged in the evening. And the best thing is the patient has a very good symptomatic relief and is able to return to work very fast. But most important thing is the timing of surgery. Most patients who comes to us is usually having the cervical pathology for almost 1 to 2 years. And still, we advise them posterior cervical furanotomy because in Western countries on all, posterior cervical furanotomy is always preferred than anterior cervical discectomy. And but for in our part of the country, I don't know, posterior cervical furanotomy has not gained that much of popularity. I think by the coming time, this will gain much of popularity because this is much easier. And has good results as compared to other surgeries. Thank you.
Thank you so much, Abu, for sharing that very exciting and fascinating experience. You have really raised the bar of both minimally invasive and daycare surgery in Trivandrum. Thank you so much. May I request a quick comment or question from moderators, Dr. Jacob, Dr. Prakash, Dr. Sunil, Dr. Jyotish, Professor Satish.
A very nice talk. Actually, the posterior furanotomy probably is one of the cases which is very ideal for the minimally invasive approach. And I think what you've shown is a very good case and a very good example of what this minimally invasive march is going to be towards more and more minimally invasive approaches. Also to consider more and more minimally invasive options, because furanotomy was a procedure that had already been probably cast to the wayside after the development of the anterior cervical discectomy. And resurgence of this has basically been because of the development of the tube and the endoscopic technique also, especially among South Korean neurosurgeons. So I think it's a very good example that you've given. Good talk.
Thank you for this.
One more thing is that this is most suitable for a soft disc. Soft disc, it is good, but if it's not a soft disc, it will be difficult. But in some cases, we get relief even in case of hard disc or osteophyte cases. But best thing for the soft disc, acute soft disc.
Yes, sir.
Best procedure.
Yes. Yes, it is. In our experience, it is very good for soft disc, but in certain conditions, even in hard disc, a patient who had a marginal foraminal or root compression with no symptoms suddenly developed a root pain. suppose in an old patient, a 48 or 50, 55 year patient who doesn't have a radicular symptom, suddenly raise a radicular symptom with a looks like a soft disc extrusion. It's also useful because just doing the foraminotomy will very often we always go for a disc, but even simply doing the foraminotomy will give you a good relief. So it is not reserved for soft disc. It is also reserved for hard disc, which has got an acute presentation following soft disc extrusion in which is confirmed with an MRI.
Thank you very much, Ajith sir, for sharing that very fine point about the technical nuance of surgery. And if everybody would permit, I think we could probably move on to the next speaker. Dr. Robert Mathew perhaps requires no introduction to the neuro circles of Trivandrum. Sir has been a world-renowned expert in the field of dementia, and it's our proud privilege to welcome him today to tell us about the aspects of dementia in normal pressure hydrocephalus. Robert, sir, please.
Thank you very much, Dr. George, for giving me this wonderful opportunity. Dr. Malini also, and thanks to Thomas Iype sir and other office bearers. It's very nice to be back after quite some time. I remember those days where I was the secretary of the Trivandrum Neuro Club, and we had problem in getting sponsors, we had problem in getting people to attend, and problem in getting speakers, all levels. It was very interesting. So I'll get to the topic. Normal pressure hydrocephalus. We think that it's a simple disease, a triad, and a treatable condition. So whenever a question is asked about treatable dementias, NPH is one among them, one among the top ones. But then when you get into the real situation, it's a very, very tricky disease. Once in a while, you come across such topics. Is NPH a valid concept? In 2002, in JNNP, there was an article. And then in 2011, in Neurology, there was an article. Is there an entity called NPH at all? And then the latest one, 2017, none less than Lang et al. In Annals of Neurology. Is there everything? So when you get into more and more details of this condition, it is nothing is really very solid. In spite of, so it was described earlier in 1965, or even before that, but even at the end of so many years, there is no robust evidence telling that it is a treatable condition or shunt is a treatment of choice. 3 Cochrane reviews, nothing to really support shunting, and shunting has variable results, short-lasting results, unpredictable, and it has significant risk. So at the end of so many years of first description, things are still in a very, very fluid state. And there's a practice guideline, which is in 2011, which came in Neurology, something like a consolation. And they came to a conclusion that shunting is possibly effective based on 3 class 3 trials. That's all. So what I'm trying to highlight is a lot of things need to be described about NPH. A lot of things are there which is not very clear in NPH. And NPH as a demanding illness is all the more less described. So I'll be dealing with this under 3 headings, short headings: cognition in NPH, neuropsychiatry in NPH, and NPH presenting as psychosis. I'll just finish off in 5 or 10 minutes. So the classical description, dementia in NPH is the answer comes like frontal subcortical dementia. So it gives us a feeling that it is very much established that this is the dementia. And it's the frontal subcortical dementia is characterized by executive dysfunction, psychomotor slowing, mood symptoms, and apathy. Okay, so it looks like everything is very well described. You have a hydrocephalus, so you have subcortical fibers getting involved, and all these things are explained. But if you get into the details, you will understand that this has been described based on very, very few studies. Very few studies means the sample size is very low. So very low for a disease that has been in vogue for quite, say, more than 50 years now. Let us just briefly rush through it. The first one looks very impressive, 101 idiopathic NPH patients described. But then it is a description of improvement in cognition. The article doesn't describe anything in depth about cognition. So based on some subjective assessment, there was some improvement, and that is all. The second study, based on 11 patients with the NPH, very small number, but then some detailed neuropsychological evaluation was done, but it's too small. Third one, 2002, looks attractive, 51 idiopathic NPH patients. And the neuropsychological battery used also looks good, MMSE with a lot of other batteries, including stroke test, symbol test, etc. No, the battery is not exhaustive. Still, it is a little, it is there in depth. However, the article doesn't describe the cognition in detail. The article is basically on the response to treatment, response to shunting in patients with NPH. So, and then there is another one study by Miyoshi et al. And study in 2004. So these two ones, especially the study in 2000, the one which came in 2006, I'm sorry. So that was the one in which 21 patients were studied, and they were compared with 42 AD patients. So the neuropsychology, the cognitive profile, or should be compared with AD, then only we'll get at least some idea. So that was one study which was fairly good, and that showed that even though memory was more preserved in AD when compared to NPH, other cognitive domains also were involved. So the classical description of this being a executive dysfunction was rather expanded, and it was found that the cognitive impairment was extending into other cognitive domains also in a very handful of studies which are acceptable. But even then, those studies are very small, that, to be very honest, we don't know really what exactly the cognition is in patients with NPH. So this is another one, a 32 number. This is also a little well done study. And in here also, the finding was that in addition to frontal executive dysfunction, posterior cortical functions are also impaired. So it's not just so the impairment of the posterior cortical function cannot be explained by the hydrocephalus. So the cognition in NPH extends to more than just subcortical cognition. And this is one of the one among the last among the list. This is also a very small study. This is an Indian, and here this was done in patients who are having NPH, and the cognition was it was a cognitively advanced NPH patients. This was the test battery used, but analysis was done only based on the Edinburgh Cognitive Scale. I'll just come to the conclusion of the study now. So this is these were the findings. To summarize it, it was the NPH group was compared with the Alzheimer's disease group. So Alzheimer's disease, there were 15 patients, and NPH 23 patients, and most of the cognitive domains remained the same, or there was not much of difference between the two groups. So the conclusion was that as advanced NPH shows cognition, advanced NPH shows cognition similar to Alzheimer's dementia. So the pathology correlate of dementia in NPH may not be the hydrocephalus alone. However, it was a very small one. So the conclusion of the study so far, or what is the cognition in NPH as of the present knowledge? Studies are grossly inadequate. I think that will be the first statement. See, it was initially thought as a frontal lobe dysfunction, but more and more cognitive domains are reported as getting involved. And ventriculomegaly may not be the only reason for the cognitive abnormality in NPH. So at least we need a uniform test battery to examine these patients, larger numbers to be studied. Of course, there's a good scope for research in this. Neuropsychiatry in NPH, there are no studies at all, I would say. Just a handful, still lesser number. The guidelines of 2012, the Japanese one, which is widely quoted, doesn't mention about neuropsychiatry in NPH at all. And the guideline in 2021, it speaks about, there's a small paragraph on neuropsychiatric manifestations, and 6 studies are quoted. Of this, there are only 2 studies which is descriptive of neuropsychiatry. One is on the postoperative improvement in neuropsychiatry, one is on radiology, and the 2 are on correlation with gait. So using a detailed test scheme, it has been described, it has not been done, good study has not been done. So of the 2 descriptive studies that has been mentioned in the guideline, this is the one that is mentioned as the first one. Neuropsychiatric manifestations of cognitively advanced idiopathic non-pressure hydrocephalus. So this is a 2018 article. So I'll just, no, I won't go into the details. So this is how it is. Now, the taller the bar, the more the impairment. So the impairment was maximum in motivation. So this is easily explained by the frontal lobe dysfunction theory. And then memory also was impaired. This is not easily explained by the frontal lobe dysfunction theory. So now this is in comparison with one more study, which is again quoted in the same article, where it was found that the difference were between the 2 studies, it was more or less the same. And when compared with patients with dementia in this study, there was no, with Alzheimer's dementia, again, it was found that the intensity of the neuropsychiatric abnormalities were less in NPH when compared to the intensity of symptoms in Alzheimer's dementia. It was also, I would conclude that neuropsychiatric manifestations are very, very common in NPH, as common as in other dementias like Alzheimer's dementia. So this also needs further characterization. And again, there's a scope for extensive, there is a vast scope for study in neuropsychiatry of NPH. And the last one, there are cases, other presentations also of NPH. This is one where NPH presents as psychosis, or patient has psychosis for years, and then they develop gait abnormality or some other features, and then they are diagnosed as having NPH. There's a case where hydrocephalus presented as psychosis, shunting improved the psychosis, then patient developed shunt failure, again patient developed psychosis, and there was a correction done. So twice a correction was done, and twice there was an improvement. So there was a close temporal profile also. And the third time again there was hydrocephalus, again psychosis, and patient refused treatment and continued to be in psychosis. I think that's the last slide. So this will be my conclusion. Long way to go in NPH in general and in the cognitive part of NPH in general. Thank you very much for a very patient hearing.
Thank you so much, Robert sir. It was a very, very fascinating talk. And most importantly, you took us to those corners of NPH which we had probably never visited before. Most importantly, you also broke the stereotype that, most people in private practice are not very academic. So that's a stereotype that most people have, that institutions have academic people, while private institutions do not have too much of academics. But you have very well broken that stereotype and taken us to so many unheard of aspects of NPH. Thank you so much. May I request our moderators or anybody who's in this webinar to please contribute your views on this fascinating disease, normal pressure hydrocephalus.
Mathew sir, I would like to just make an opening but regarding the studies that you had shown in Cochrane. Do they specifically relate to cognitive improvement following shunting, or do they relate to general improvement following shunting?
General improvement, any improvement.
Sir, I think on that count, actually, I just have this. This is an article that was published in JNS in 2018. Very large series. Had a lot of modern studies which date after 2000, especially between 2010 and 2015.
Okay.
And meta-analysis amounts to nearly 2,500 people. It's a very important. It's a very important study because it accounts for various modalities of treatment. Also, it accounts for treatment using a ventriculoperitoneal shunt, a ventriculoatrial shunt, lumboperitoneal shunt, and ETVs also. And the study is very conclusive in that it demonstrates what we've known very often, that the improvement most commonly happens with gait. So ataxia improves in a significant amount of people, that is nearly 75%. Incontinence in less than 50%, and cognitive improvement is the least of the factors that improves following shunting. Ventriculoperitoneal shunts do very well because the extent of complications, especially subdural hygromas, are less. And with the presence of anti-siphon devices and valves, the complications, including complications like subdural hygromas, are minimal. ETV of these procedures is probably the least important and has probably shown the least amount of improvement in any of the parameters following management. So ETV should not be considered. So these were the conclusions. It is important because all the studies that were included in this had very standard definitions of NPH. Now, unfortunately, NPH also in different groups has been classified differently. So if the point is that there is very little improvement in cognition following shunting, I agree. But if the point is that there is no improvement following shunting in any of the parameters, then I'd like to disagree.
No. The point is we don't have enough evidence in any direction. Anyway, whatever you said about shunting is acceptable.
Dr. Robert, I was wondering whether all those patients that you are seeing, whether they could be having a coexistence of Alzheimer's, dementia along with NPH along the way?
Very much possible. Already there are studies showing that when brain biopsy was done in NPH patients, more than 25% had increased plaques. So already there are, I don't know.
So that may explain why that part of that parameter doesn't get resolved with just reducing the ongoing pressure difference.
Very, very likely. And that also has already been postulated also. So the patients whom we collect as NPH patients may not be really NPH at all. No, sorry, may not be having NPH alone. They will be having a lot of comorbidities. But how do we segregate them? And how do we get a homogeneous collection of NPH patients? All these are issues.
Can I request Dr. Ramshekhar for a final view on the dementia perspective of NPH?
I'd like to thank Robert sir for sharing his experience. I totally agree with Robert sir. I think probably he's raised a very pertinent issue with regard to the fact that there may be no entity such as idiopathic NPH, and NPH is likely to be possibly secondary to some underlying etiology. And as Prakash said, the pre-existing cognition is a very important marker with regard to what would be the long-term outcome of a patient who is subjected to shunting. So a patient who has a pre-existing quantified marker, which is very less, that is in the form of a neuropsychological test score, which may indicate significant dysfunction in global domain or executive domain or memory domain, those patients are unlikely to undergo a significant change with regard to their radials following shunting. Whereas there might be transient improvements in gait, but gait is also very well known to be an effect of a higher order cognitive process. So it would be interesting to see what would be the natural natural outcome of these patients of NPH who undergo ventriculoperitoneal shunt and initially demonstrate a significant improvement in gait, and then subsequently how would their cognitive trajectory would be. So I think for that you need to have 3 time points of cognitive trajectory mapped out to really demonstrate that particular thing, which is not an easy job in itself. As rightly said, they may be having associated comorbidities, which may be vascular, which may be Alzheimer's pathology, or it may be a mixed pathology. Alzheimer's dementia, as was being suggested, is essentially a mixed disease. That's not only the amyloid plaques, but also the vasculopathy. And perhaps one way to differentiate, as Dr. Robert Mathew was probably suggesting, is that if you want to have that cohort of idiopathic NPH, you should segregate those patients who have a significant non-confluent white matter burden on the MRI. So you talk about periventricular ooze and periventricular seepage and confluent white matter hyperintensities. But you have to actually have a quantified measure to segregate the non-confluent white matter hyperintensities, which are seen on the MRI, to say whether the patient is having an underlying vascular pathology or an underlying mixed pathology. And of course, PET studies and amyloid PET imaging would be the ultimate thing to do in patients with NPH, and these are not available in India. But I think there are some studies which have shown that the CSF tau ratios as well as the CSF amyloid beta 42 ratios among patients with NPH is comparable to that of patients with AD. So I very much agree with what Dr. Satish suggested, that most of these patients are likely to have an underlying pathology, and there may be no such entity called idiopathic NPH. Just a thought. Thank you, sir, for sharing your experience.
Thank you very much, Ram, for sharing that view. Special thanks to Prakash and Satish sir for giving us a neurosurgeon's perspective to NPH and its associated dementia. Perhaps it's time for all of us to pool our experience together and maybe have some form of a multicentric study to evaluate the outcomes of NPH after a shunt. Thank you very much. And since we have both our next speakers sitting in surgical scrubs, it would not be fair to delay it any further. It's my proud privilege to invite Dr. Navas, who will be speaking to us about a very uncommon entity, that is dorsolumbar disc disease, and newer paradigms in its management. Dr. Navas, please.
Navas sir, unmute.
Thank you, George sir. Good evening, all. Am I audible?
Yes, Navas, you're audible.
There are no disturbances, right?
No, you're perfectly audible.
Okay, thank you. So just the last half a decade, how the management of lumbar disc disease or thoracolumbar disc disease have evolved or changed is what we will go through. We'll go through some case discussions and see how we have managed them in the last 2 or 3 years. So the case one, patient presented with say right L4 radiculopathy, foot drop, quadricep thickness.
Hello? Please stop sharing your screen. It's not visible.
Is it visible now? Hello?
Yes, sir.
Yes, Navas, we can see it.
Fine. Okay. So we will go case by case. So this is a 50-year-old male who presented with a right L4 radiculopathy. This is his axial MRI. So first look, we may miss the disc, but there is an extra foramen. This is the coronal view. You can appreciate it well. And here the foramen is free, and after the foramen, you can appreciate the disc. So purely extraforaminal disc. So what are the options we have? Any suggestions from the audience? I mean, conventional approaches won't do. I mean, conventional approach for this one don't. So we have to go maybe paramedian. There is the transverse between the transverse muscle splitting open approach. So what we did was we did minimally invasive muscle splitting intertransverse approach, where we placed the tubular retractor on the L4, dock it on the L4 transverse process. So we have docked it on the L4 transverse process, and you can appreciate the root. We have removed the muscles and the intertransverse ligament, and you can appreciate the root. Usually the root is pushed posteriorly or superiorly in case of an extraforaminal disc, and the root is stretched. And, you can appreciate the disc. So in the image, it is shown as a quadrant image. We have used a 18 mm tube, which is more than sufficient. And in this case, the root was pushed superiorly. So no violation of facets, no muscle cutting, just muscle dilatation and finally the root is free. The last bit is smooth. So again, coming to case 2, again you can see at the L4-5 level there is end plate degeneration. The foramen is not visible. Foramen is as a disc herniation. The axial image, you can appreciate it. Purely foraminal disc. Failed conservative trial. What are the options available? Conventional approaches will be suboptimal and will give suboptimal results. We all know. Without, or we do a medial facetectomy, and even medial facetectomy won't help in moving the disc, or maybe it may cause instability if you overdo it. So what are the options? So literature says about an option called lateral pass intra-articular approach, where you drill only the lateral half of the safe zone of the pass, so you don't cause a fracture. You're not supposed to drill the red area, only the green area is supposed to drill, and you can remove the disc. So this is one option that is given. This is purely, so you don't violate the facet, and you can remove this. But in this case, actually, we did an MIT lift because the patient had end plate degeneration as well. We did an MIT lift, removed the facet on that side, and patient had a fusion. In case 3, this is you can see as L4-5 disc is superiorly migrated, and it is compressing the axle of the L4 root in the lateral recess. So this is a lateral recess disc. I mean, for this, I think the conventional approach was enough, and this was minimally invasive, 15 plain disc, and the probing yielded the disc. I can appreciate that. So next case will be, so this guy is 50 plus, 55, had undergone discectomy at our center 2 years back, presented back with again with the left S1 radiculopathy. So this is MRI. So he has a recurrent disease. He was also given a conservative trial, but failed. So this is a recurrent lumbar disc. So what are the options now? So what are the risk factors for recurrent disc? Younger age, lack of a sensory motor deficit, and a high ODI score are risk factors for recurrent herniation. And as well as smoking, diabetes, obesity are all mentioned. Then certain biomechanical factors are mentioned. Preoperative disc height is a well-mentioned risk factor. Smaller the disc height, the higher the chance of recurrence. And range of sagittal motion of range of more than 10 degrees also suggested a risk factor. So this patient, whether it was a confusing whether to go for a discectomy alone, since he has failed a conservative trial, to go for a discectomy alone, or should he go for a fusion? That is decompression alone, or decompression and a fusion. So this is his full spine. The aspect of sagittal balance comes into play. This is his full spine standing X-ray. You can appreciate that his plumb line is anterior, and he has a SV of more than 5 centimeter. And this he has a type 2 black back, that is a flat back. According to Rosolli's classification, it's a type 2 back. Cycloslope is less than 35. This is Rosoli's classification. So he has a type 2, which is a harmonious one, but it's a type 2 one. So type 2 back or a flat back is a back with a low lordosis angle. The interval displays are horizontal, and this causes an increased stress in the L4 and L5 and this resulting in the early degeneration. So this person was supposed to have recurrent sagittal imbalance. So we decided to go for a discectomy and fusion. So for him, we did a TLIF. We had used an expandable cage. Interbody device. You can see the final X-ray. Now about one more case 5. And this is guy 70 plus guy presented with features of neurogenic claudication. Again, multi-level. L4-5 is the most severe. You can appreciate that. So is there a listus? In 20% of cases, listus is undetected on lying imaging modality. So you have to get a standing X-ray. So our guy, this was a standing X-ray, dynamic X-ray, which showed a listus. So 70 plus guy, canal stenosis, multi-level with listus, degenerative listus. So in degenerative spondylolisthesis, does the sagittal balance matter? So we should know the natural history of degenerative spondylolisthesis. So this is a predisposing morphotype. That is a type 3. Type 3 and type 4 are the most predisposing one. Type 3 is a predisposing, the one with a greater PI and a more lordosis. So as the progressive development of local loss of lordosis occurs, there will be slippage of disc and degeneration. And as the disease progresses, regional compensation with multi-level loss of lordosis occurs, but the global balance is always preserved. The plumb line will always remain the same, but local regional compensation occurs. So again here, degenerative spondylolisthesis 70 plus. Whether we should go for a decompression, posterior fusion, and literature says bilateral TLIF with pitch phages are the best because they increase the lateral lateral canal diameter, foramen diameter. So again, this things occurs. What we did was a MI level TLIF 2 level with expandable cage because he had this is progressive one. Decompression alone would we thought would not alleviate this. Which is expanded, then the cage, the uppermost one. Again, and this is the final image. So he'll underwent 2 level TLIF with expandable interbody device. So basically, this degenerative spondylolisthesis is a stenotic and kyphotic degenerative disease. So our surgical concern should be address both stenosis and kyphosis. So this expandable cages will bring back the lordosis and of course TLIF, and this will go indirect decompression of the foramen and delay the stenosis. So I will just go through this study. Sagittal imbalance as a risk factor for adjacent segment disease in post-lumbar interbody fusion patients. So they say that a PI-LL mismatch of more than 10 degrees has a 10-fold greater risk of developing adjacent segment disease than controls. So the preoperative sagittal imbalance of SVM more than 50, higher pelvic tilt, PI-LL mismatch are significantly associated with adjacent segment disease. So therefore, even with a single level PLIF, appropriate sacral lordosis and some lumbar lordosis should be obtained at surgery to improve a spinopelvic sagittal balance to avoid development of an adjacent segment disease. So how can you attain this local lumbar lordosis? I mean, hyper wedge cages. In extreme cases, you can do vertebral column resection or a spinal osteotomy. So as you notice, we are using expandable cages in TLIF now. So should expandable TGF cages be routinely used to increase lordosis? So I will give you some data. I mean, expandable devices increase foraminal and disc heights more than a static device. They increases index level segmental lordosis, but has no effect on overall lumbar lordosis. They do not affect pelvic parameters, but they do result in better ODI scores. And both have similar pseudoarthrosis rates. But the point with expandable interbody devices is that the ability to place an initially smaller interbody implant. So you need a smaller entry point, and then carefully expand it so that it can produce significant segmental lumbar lordosis correction without associated trauma and adverse effects. That is the iatrogenic end plate reception during what can happen during static cage insertion. So less trauma to the end plates and less cage subsidence. And this is it. Significant subsidence has not been reported in literature, and therefore not a major concern as long as the end plates are carefully prepared and the cage is not overexpanded. So the global analysis, that is sagittal balance, including cervical spine and head is nowadays mandatory. Sagittal balance must be carefully considered before any surgery, limited or not, and especially at the L4-5S1 levels, which represent 66% of the lordosis when they are included in fusion. So what is this shift? What has caused this shift in the last few years? I mean, one is techniques have become minimally invasive. So mostly, I mean, more than 75% of spine cases are now being handled minimally invasively. And use of sagittal balance, assessment of sagittal balance in the management and incorporating it into treatment modality has occurred. And novel gadgets have brought a shift in this management of lumbar disc disease. Thank you.
Thank you very much, Navas, for shifting the paradigm and taking us to greater heights. Thank you very much. May I request our experts to please give a few comments, Professor Krishna Umar, Dr. Sachin Baldava, Dr. Sunil sir, Professor Satish Krishnan, Dr. Sanu, Dr. Thomas Varghese. A few viewpoints from your side, please. Dr. Tinku, Dr. Kiran.
Dr. Navas bhai, can you hear me? I am Dr. Sanu.
Sorry, bhai. Hello.
Yeah, excellent talk. Just want to ask one thing. What is the level of lordosis? How much is the lordosis you can achieve with a single level expandable TLIF? Have you assessed it with a preoperative and postoperative?
We have done, but I mean, it may look good on X-ray, but maybe when you assess, I mean, when you globally, it doesn't change much.
No, then just clearing my doubt. Then what is the advantage of going for an expandable TLIF over the normal TLIF? If I mean, if at a single level postoperative doesn't make much difference, or you have to go for maybe two levels.
It makes difference. That was my final slides also about. I mean,
can I answer that question?
Yes, of course. See, this was my slide about that. They increase and foraminal and disc heights more than a static interbody device, but has no effect on overall lumbar lordosis.
So how can we include it or as a gadget in our effort to correct the sagittal balance?
No, I mean it isn't, but it helps in relieving adjacent segment. The hyperwedge cages help in. We are bothered about the adjacent segment disease. So I mean, progress of adjacent segment disease can be prevented. Lordosis. Segmental lordosis increases anyway. but has no effect on overall lumbar lordosis.
No, if it doesn't have any overall.
It doesn't mean that static interbody devices don't achieve this. They do achieve this, but I mean expandable interbody devices achieve it much. Is what I understood from literature.
Like what exactly? That's what I was asking.
Yeah. May I answer that question? Sure.
Yes, sir. Sir.
Yeah. Actually, according to the vendors, this expandable lordotic cages will give a 9-degree additional increase in lordosis per level. Okay.
Okay, sir. Exactly. That's what was.
So if there is a PA, so there is a local imbalance, that is a spinopelvic imbalance, that the PALL mismatch is there. By increasing the lordosis, you can shift the plumb line back in posteriorly. Okay. If the sagittal balance is anterior to the bifemoral axis, we can shift it back by increasing the lordosis. Okay.
Yes, sir. I understand, but just I want to clear my doubt. What I was asking is incorporating this as a gadget in correcting the sagittal balance, this expandable T-lift cage. Like how if it doesn't make much correction in the overall lordosis, what is the advantage? Is there any regarding the cost factor? How much does it differ, like from a usual T-lift cage and expandable?
You may not need a expandable cage. If you can afford, you can go for expandable cage. But unaffordable patient, you can use a T-lift cage. T-lift cage up to 13-14 millimeters. You can push anteriorly and then compress and increase the lordosis.
What is the cost, sir, of an expandable T-lift cage when you compare it to the normal T-lift cage? The cost?
Cost, I don't think it is around 50 or 60,000 rupees.
60,000.
60.
So
the beauty with the expandable cages are you can, because when you are using a T-lift cage, it is very difficult for you to put 14-15 millimeter cages. So with the expandable T-lift cages, the T-lift cages are, when you insert, it is only 11-10 millimeter. Then you can gradually expand it to 15.
For that, you can better go for an OLIF, no, sir. Without
OLIF, the problem is OLIF, you cannot directly decompress the foramen. And second thing, OLIF, you need 2 surgeries. First, you put the OLIF cage. Then again you have to do a T-lift posteriorly. This you can do in a single sitting. Another advantage is OLIF doesn't address if in an osteoporotic bone, if you open and if you see this osteoporotic bone, this T-lift, there is a scissor etc. But for this expandable cages, what you can do, there is a jack, scissor jack like thing. With that thing, you can increase the disc height. Increase it slowly. So you can increase
the same thing can, and for an osteoporotic bone, this jack phenomenon, like what you use as a spine jack, you use that technique for even for vertebroplasty, like kyphoplasty. So they have this technique of spine jack. You introduce the kyphoplasty, and they have the jack-like technique to dilate the bone. That is the same technique is used for kyphoplasty. So in an osteoplastic bone, there can be problem with the end plate degeneration, isn't it? If you use this jack technique.
OLIF is
not OLIF, not OLIF. I'm just asking about this expandable T-lift. So you told you can be used in case of osteoporotic bone, but this jacking phenomenon can affect the end plate viability, isn't it?
Yeah, definitely. With the osteoporosis severe, this can definitely affect the end plates. But what this jack uses, it is uniformly displacing the force so that the end plates will uniformly increase. But whereas when you use a OLIF, you are inserting a serial expander one by one.
Okay.
So that can damage the end plates.
So what my question is, spending an extra 60,000 for an expandable T-lift.
You don't bother about the money. You don't bother about the money. If you don't have money, you can use a T-lift cage and push it anteriorly and compress. Okay.
Yeah.
Whatever is needed, that you have to do. You can use a gadget, expensive gadget for all these things. That's okay if patient can afford. If patient can't afford, you can put a T-lift cage and you can push it anteriorly and then you can compress, then you can increase the lordosis.
Yes. Okay, sir. Okay. So
you can get it for 10. You can T-lift cage, you can get 10,000 or 15,000 rupees. but
Yeah.
who can afford, and for the
Yeah.
surgeon also it is very easy.
And now the straight T-leaf cages are available, rather than the old, exactly like the bullet T-leaf small cages. Now straight T-leaf cages are available. Not exactly the expandable one, which can be put across the disc space. It is much longer and larger than the usual cliff cage, which is used with anterior that height difference, anterior width difference more than the posterior, which can be put across the vertebral body end plates, and which can give better maybe up to 9-degree low doses. It's straight T-leaf cage. It is available outside, and even it is available here also with our company.
But the problem is fixed height cages are, if you want to put a higher thickness cage, that is 15 or 16 millimeter cage, it is very difficult to put in through the Camden's triangle. Okay. So expandable cages are a better option if you want to put a higher cage without much damage to the exiting and traversing route. That is my take on this.
Okay, sir. Okay. Fine. Thank you, sir. Thank you so much.
Thank you very much, Sanu and Ajith sir, for taking that discussion on spinal biomechanics treated with new gadgets to a absolutely new level. Thank you very much, Navas, for that fascinating presentation. Our next speaker is always full of enthusiasm and energy, be it academics, be it art and literary presentations, or anything for that matter. It is my proud privilege to invite Dr. Rosemary, and it's time to get very alert now, because Dr. Rosemary is going to speak to us about ALERD-Acute Leukoencephalopathy in with restricted diffusion. And I must confess that I have no knowledge of this entity. Dr. Rosemary, please.
Can you hear me, sir? Am I audible?
Yes, we can hear you.
That is, it puts me at peace, sir, that you don't know anything about it. So it'll be easier for me then. Just one second. I'm not very sure how to do this.
Yeah, we can start.
This?
Yeah, we are able to see it. You can go to the presentation mode. Yeah, that's fine. Perfect.
Good evening, everyone. I'm very thankful to the organizers of Trivandrum Neuro Club for giving me this opportunity to present in front of you. So I'm going to speak about probably not widely known entity called ALERD, which stands to acute leukoencephalopathy with restricted diffusion, especially the Indian scenario. I'll be focusing on the Indian scenario. So what exactly is ALERD? It's a clinical radiological spectrum which is characterized with acute onset encephalopathy and a restricted diffusion, especially in the subcortical white matter. This has been extensively reported from East Asia, especially Japan. However, there are reports from other areas also, but there are just one or two. Even from India, most of the reports were as case reports. But we have now come up with a few case series, which I'll be talking in later. So the first terminology that came up was acute encephalopathy with biphasic stasias and late reduced diffusion. It is also known as AESD. So this was the classical description that came up in a cohort of Japanese children by Takanashi et al. In 2006. So what it described was a biphasic course where the first phase was characterized by a prolonged febrile seizure with a mild encephalopathy on the first day, which used to follow followed by a period of apparent stabilization. And then there was a phase of seizures and a worsening encephalopathy between the 4th and 6th days. On the other hand, the MRI brain in the initial 48 to 72 hours used to be normal. And then later on, between the 3rd and 9th day, there was restricted diffusion involving the subcortical white matter. So this was the clinical picture of AESD. Later on in 2009, a study by Okumura et al. Described two different MRI patterns. One was that of central sparing, which showed a lack of reduced diffusion in the areas around the bilateral sylvian fissures. These areas were spared, hence the term central sparing. Though diffuse abnormalities were typically present in other areas of the MRI imaging. Whereas diffuse did not have that sparing, and it used to involve the whole cortex and the subcortical white matter in bilateral hemisphere. So there were salient differences between the two MRI patterns. Central sparing was presenting with a milder encephalopathy, and it had the biphasic course. A deep coma was uncommon, and the laboratory abnormalities were mild and not much of mortality. However, diffuse was characterized by a severe encephalopathy with a rapid deterioration. Sometimes seizures were not associated with this. However, previously there was a biphasic seizure patterns noticed in the AESD. Here, this was not always seen. And the clinical course was mostly monophasic, rarely biphasic. So, and they were associated increased laboratory abnormalities like increased AST, ALT, creatinine tannins, hyperglycemia, metabolic acidosis. And there was clinical further deterioration in the form of MODS, shock, and DIC. And definitely this had a poorer outcome. So this is the picture. This is from study by Hayashi et al. It's first one shows a diffuse form where you can see diffuse involvement of the subcortical white matter. It's also called as a branched tree appearance. And here you can see this central sparing. This study also described a unilateral involvement. This one shows the typical central sparing, where you get a high intense diffusion restriction in sparing the perirrhombic region. And then you see the corresponding low signals in the ADC maps. So yeah, and this is the diffuse form. So here we have an involvement of the basal ganglia also, and you see subtle hyperintensities in both the T1 and the flare images. However, the T1 remains normal. Now coming to the differentials, so there were many considered. The most common close differential is the acute toxic leukoencephalopathy, where you have similar bilateral symmetric confluent areas involvement, but mostly in the periventricular region. There is no or mild mass effects, and there is no enhancement there. Other higher susceptibility areas are the deep gray nuclei, cortical gray matter, thalami, periventricular white matter, and corpus callosum. Acute ADM, as you all know, is usually multifocal, has asymmetric lesions, involves deep subcortical white matter, deep gray nuclei, posterior structures, and has less prominent and less common restricted diffusion. ANEC also has a characteristic necrosis and hemorrhage of bilateral thalami. There may be involvement of the cerebellum and the white matter also. Now, PRESS also has a prominent posterior. It is usually bilateral symmetrical, and it mostly has a posterior region involvement, both of the subcortical and cortical region. However, the edema here is vasogenic. So there'll be a facilitated rather than diffusion restriction. And MERS is another entity you usually seen in pediatrics, where you get an oval-shaped lesion in the median aspect of the splenium of corpus callosum. It can sometimes involve the whole of splenium, and there can be additional lesions in the white matter, but usually they are very short-lasting and they'll disappear within 1 week. So coming to the Indian scenario, there are, as I said before, lots of case reports. The term ALERD was first coined by Dr. Mahesh Kamte. He came with a comprehensive review in the year 2018. However, there were no case series or larger studies from India. So this year, we have been fortunate to have 2 studies, one from Mahesh Kamte all, and the other I was fortunate to be part of when I was doing my intensive care training, where we chose 11 children from a group of 78 children who presented to us with fever and encephalopathy, and who were retrospectively studied, and their MRI was evaluated by a neuroradiologist to look for features of ALERD, and were chosen into the study. So we had 11 cases here, whereas Kamte all had 16 cases from last 3 years. Ours was from 1 year. So we had salient differences. Before that, I would like to see how the clinical criteria evolved over the years. Initially, there was the AESD, which had a strict clinical criteria of fever with seizures and a deterioration of seizures and associated high signal intensity subcortical white matter. However, the later studies described something called acute encephalopathy with reduced subcortical diffusion, which did not have fever as a must. Seizure onset and the typical MRI picture would suffice. And in the Indian context, we used a clinical criteria of fever and encephalopathy with or without seizures and an MRI, which was typical. So now coming to the salient differences that we noticed between Japanese and Indian cohort, the main aspects where they differed were the clinical presentation, etiology, imaging, and outcome. So Japanese clinical presentations, there was a female preponderance, 93% of them were biphasic in presentation, and seizures always was present, and usually it was prolonged in the first phase. Whereas in Indian studies, both it was a male preponderance, and only 6 to 18% were of the biphasic course, and seizures usually were present but were not present on all cases. In fact, we had one, and our company also had just one patient who did not have seizures, but it was not there in all the patients. Etiology-wise, Japanese studies classically describe the commonly implicated viruses like HHV6, influenza A, echovirus type 3 and 9, and RSV. Rarely there were reports of other organisms like enterovirus, mycoplasma, E. coli, streptococci, etc. But these are all 1 or 2 in number. In India, only our study dealt with the etiological aspects, and we came up with dengue as a major etiology contributing for ALERD. As you can see, this is our data. We had extensively worked up, and we had predominantly dengue. We had 4 which were unknown, but we had sepsis also, and one case turned out to be GST type 6 also. So coming to imaging, Japanese had more central sparing type of MRI picture, which was typical in ASD. And Indian, we had more of diffuse lesions, so which is more, which is of the more severe type, as per Japanese descriptions. However, in outcome also we had certain differences. Though there were some common points, the mortality for us also was some low, only towards 5 to 9%. Japanese literature describes it as less than 5%. And there were varying degrees of cognitive impairment in both cohorts. There were post-encephalopathic seizures and behavioral problems also noticed. Then monophasic course and a prolonged ventilation, basal ganglia involvement were associated with a poorer outcome. However, in Japanese studies, MODS or shock seen in clinical, was associated with a poor outcome. But in India, in our studies, what we noticed was it is not, we cannot form an association. However, what we noticed was that MODS or acute liver failure was associated with a better, relatively better outcome with a higher average DQ or an IQ also. And in Japanese studies, the prolonged seizures shown to have poorer outcome, whereas for us, there was no such increase in, poorer outcome. It was comparable for us. And the additional point that we noticed was that a known etiologies showed a slightly better outcome. This is our this thing. As you can see, prolonged status, comparable average IQs, and MODS present, we had a higher IQ or a DQ. Here also we had a higher IQ or a DQ. Mortality also, cognitive deficits also were better in the ones with where there was MODS and ALF present. Etiology also, when they had a known etiology, it was slightly better. Definitely, we cannot make a significant association in present, but probably these are things that we have to look into. So there were previously many hypotheses regarding the pathophysiology. It's still a mystery. But what they say is, Japanese studies say is that there is a glutamate-mediated excitotoxic injury leading to prolonged seizures and a poorer outcome. However, that was not so in our study. Similarly, there is a hypothesis of hypercytokainemia, associated with MODS or shock, which is also having a poorer outcome, but as I just discussed, that is not seen in our study. So recent studies have hypothesized that a mitochondrial dysfunction associated with the thermolabile phenotype of carnitine palmitoyl transferase 2 can be a pathological mechanism for AAC. So basically, it all boils down to genetics. So probably we have to go into that aspect. So as of now, among all the literature search that we did, we could not find any definitive treatment. All of our patients were given, except two, they were given immunomodulatory therapy, but the outcomes were mostly comparable. There have been anecdotal reports of improvement with IV pulse steroids or IV immunoglobulin, but we need more randomized control trials to prove that. And definitely more research is needed to look into the etiology so as to make a difference in the treatment modalities. Thank you.
Thank you very much, Dr. Rosemary, for that very fascinating presentation and also shining a torch on an aspect of pediatric neurology and adult neurology, perhaps, that many of us were not really aware of. I'm sure there is a lot to discuss about it, and I'll just share a small trivia about Mahesh Kamte, who first described this entity. Mahesh is perhaps the first DM in pediatric neurology, because most of the pediatricians who have done DM in neurology have done it in adult neurology departments before. So he is the first DM pediatric neurologist who's done it from AIMS. I think he joined in 2004. I know very well because his brother-in-law was an alumnus of our department. Thank you so much for this fascinating presentation. May I request our experts, Mini Madam and the others, to share a few points of for discussion, please.
It was a very good presentation, and congratulations for the great series that you published. I just had, from a clinical standpoint, you have a child or a child presenting with monophasic illness with seizures and encephalopathy. Apart from the imaging, are there any clinical differences to really differentiate a viral encephalitis from an ALERD?
No, sir. No, sir. It's
just a purely an imaging-based classification, and the etiology is, it can be viral or it can be autoimmune or whatever. I mean, an inherited basis is not conclusively proven, but from a clinical point of view, it is just like a common garden viral encephalitis. And the only thing is you don't find an organism, and the CSF parameters can be mixed. I assume that CSF lactate levels were also studied in that series of yours. If you have any insights with regard to the CSF profile, it would be useful.
No, sir, we did not go into, not all of them had CSF lactate, but what we noticed is that some of them had a non-viral etiology also, like there was a proven sepsis, and dengue was definitely there. But it was basically a clinico-radiological spectrum. What triggers it, we still don't know. In fact, all the data also is not able to show exactly what is it that is triggering the presentation.
Actually, in addition to infections, there are speculations that toxins also, drugs also can produce such a picture, especially with the immunosuppressive drugs used for treatment of leukemia, especially methotrexate and also metronidazole. So it not be always virus. But then the thing is that in this situation, there will not be so much of a seizures and all. And in cases of acute encephalitis, when you go into the MRI picture, what do you like more is a gray matter involvement, and there's a deep gray matter involvement that you look for predominantly. But in this situation, there is more of a white matter involvement, and the time window is very important when you look at this. If you do it in within first 2 days, you will miss this entity, and usually if you do it after 4 days, you pick it up, because this restricted diffusion is a late restricted diffusion. It comes usually between 4 to 9 days, and after 9 days it starts normalizing also. It takes in next 1 or 2 weeks. So the time window of doing the MR sequence is also very important. And as Rose told, it may have some genetic predisposition, because not all patients with the dengue fever or influenza group of viruses. In our part of, we get a lot of cases. So all of them are not developing this particular pattern. So what exactly produces is it always some genetic predisposing things associated. Maybe also interesting to look into. And also in case where you told about the biphasic presentation, there people have looked into the MR spectroscopy also in a few cases. It is found that the glutamate and the glutamine level were elevated during the subacute stage, probably accounting for the apoptotic injury or the late excitotoxic neuronal damage related to extracellular glutamine present in there. So very nice article by Dr. Rose, and two of the main series from India. One of the series is from our own alumnus. I am very proud to know that and tell that she was our alumnus from Greater Neurology Department. Here it
Thank
is.
you, ma'am. Thank you.
Can I ask, are there any longitudinal MRI studies on, I mean, obviously these appear to be reversible, but with regard to its implications on gray matter volume or white matter morphometry, are there any longitudinal MRI studies which have looked at the outcome of this alert?
Not exclusive MRI studies, sir, but as part of a clinical profile, some of the later MRIs have been evaluated, and there have been reports of atrophy, cerebral atrophy, generalized cerebral atrophy, but that also the data is very limited. Sir.
Thank you.
Thank you very much, Dr. Rosemary, and congratulations once again for that being part of that fascinating series of ALERD from India. And thank you very much, Dr. Ram and Mini Madam, for those fine points for discussion. I think now it's the time for our 5-course meal to go into the desert. And the desert is often the most fascinating part of the meal. And for the last talk, may I invite Dr. Bobby Iype, and his endoscope will take us to many far-fetched corners of the brain. And one such corner is perhaps the cavernous sinus. My proud privilege to invite Dr. Bobby Iype. Bobby, we can see your screen. Please go ahead.
Hello, sir. Am I audible, sir?
Yes, you're audible. You just need to play and get started.
Thank you. It's been a fantastic league of very interesting presentations right through our evening. Thank you, sir. Thank you, George, sir. Again, but I am not really sure this is the right time with the second to discuss some endoscopic anatomy of the cavernous sinus. But anyway, let me just walk you through. My topic is the endoscopic approach to cavernous sinus tumors. Really blessed to have and be part of this wonderful team of skull-based surgeons here as I try to grow in neurosurgery. Now, this is a pictorial representation, as we all have seen right from our MBBS days. This is a Netter's image, and as you can see, the cavernous sinuses on either sides of the sella fossa are paired between the sinuses. Now, this is a bony relation of the cavernous sinus here. It can be compared to the hull of a boat. Basically, the keel of the boat will be almost anterior here, approximating at the level of superior orbital fissure, and there's got a lateral and a posterior wall, which is the broadest at the posterior aspect, where it is between the dorsum cellae and the petrous apex. So as you can see, these are the different tributaries and the drainage of the cavernous sinus on each side. You have the vein of the superior and inferior ophthalmic veins anteriorly, the sylvian veins which connect the middle cerebral veins from the cerebral hemispheres, the sphenoidemsary vein, the vein of the foramen vein, the vein of foramen spinosum, the carotid venous plexus that come into. And of course, it drains into the basilar venous, the inferior petrosal sinus, and the superior petrosal sinus, and also the pterygoid plexus veins interiorly. As you can see, on both sides of the cavernous sinus, they are interconnected through the anterior intercavernous sinus, the posterior intercavernous sinus, behind the dorsum cellae, and the largest of the interconnecting sinus between the two, there is a basilar sinus. Now, thus the cavernous sinus connects to the different structures, like to the orbit by the superior and inferior ophthalmic veins, the cerebral hemispheres through the middle and inferior cerebral veins, the retina by the central retinal vein, to the dura by tributaries of middle meningeal veins, the transverse sinus via the superior petrosal sinus, the jugular bulb or the interior jugular vein by way of the inferior petrosal sinus, the venous plexus by the emissary veins, and the facial veins through the ophthalmic veins. Now, as I was discussing, now let us really come down to the real cadaveric dissections by the phenomenal work done by Roten and his colleagues. We have been really, it's been really fascinating to see all this and then learn from them. So this is anti-aspect of the right side of the cavernous sinus, as you see from the lateral aspect. This anti-aspect which is formed at the level of superior orbital fissure, and the posterior aspect at the level of the petrosal, the petrous apex and the dorsum cellae as a posterior wall. So the lateral wall is formed right above from the tendoral aspect of the tendoral, the dura of the tentorium, and it comes down to the level of the upper aspect of V2 or the maxillary nerve. And the maxillary nerve, as we all know, doesn't form a part of the cavernous sinus wall. So it is till the level of maxillary nerve, it comes down. So, and again, Roten has divided the cavernous sinus into different spaces. Most importantly, the postero-inferior venous space, the postero-superior venous space, the antero-inferior venous space, and the medial spaces. As I was always saying, it can be attributed or compared to the hull of a boat, where the lateral wall and the middle walls are the widest posteriorly at the level of basilar sinus, at the confluence of basilar sinus, the petrosal sinuses, and is narrowest anteriorly at the level of superior orbital fissure. Now, the common tumors which involve the cavernous sinus are the invasive pituitary adenomas, the meningiomas, schwannomas, hemangiomas, choromas, and chondrosarcomas. Now, what happens in the open approach, we take a lateral to medial trajectory in and around the cranial nerves. We make use of the triangles that are described in between the cranial nerves through the lateral aspect or the superior aspect. Thus, the cavernous sinus are approached through the transcranial route via its superior and lateral walls. Superiorly through the clinoidal and oculomotor triangles, laterally through the supratrochlear and infratrochlear triangles, and posteriorly via the famous cavasi or the posteromedial triangle. This is another image which shows the different triangles. I will have to describe in detail, but in the interest of time, let me just quickly pass through. As you can see, the clinoidal triangle here, the clinoidal triangle is between the optic nerve and the oculomotor nerve here. It has got a very important structure, the optic strut anteriorly, the cavernous, the supraclinoidal, the paraclinoidal ICA just behind, and the oculomotor triangle or the interclinoidal fold behind. And next triangle is the oculomotor triangle, which is formed by the interclinoidal folds and the anterior anterior and posterior petroclinoidal folds. And on the roof of which, through the cranial nerve 3, enters the cavernous sinus. And again, you have the different triangles between the third, the fourth, and the mandibular and the ophthalmic divisions of the trigeminal nerve, which are named as the supratrochlear and the infratrochlear triangles here. Again, you have the anteromedial triangle, which is formed between the first and the second division, the anterolateral triangle, which is formed between the second and the third division in the middle fossa, the posterolateral triangle, which is again another important triangle which can be opened up or exposed to get a proximal control of the ICA in the middle fossa where by the control of the petrous ICA. It is exactly in this triangle that we will be approaching to control the proximal ICA in the petrous carotid level. And you have the posteromedial triangle there, and the drilling of this triangle will be called as the anterior petrosectomy to reach the posterior fossa dura and the posterior fossa. Now, this is again the pictorial representation of the same. Now, the open surgical corridors after the craniotomy, like the frontotemporal craniotomy, cranio-orbitozygomatic osteotomy, then go for an extradural approach, then you go for an anterior clinoidectomy, and then reach the superior wall or the lateral wall, either through an intradural approach or the stripping the middle fossa dura laterally. So you have the frontotemporal epidural and the subdural approach, or that is also called as anteromedial transcavernous approach, defined or described by Professor Vinko Dolenk. Then you have the anterolateral temporopolar transcavernous approach, and you also have the lateral approach to the posterior cavernous sinus through the cavasius triangle, cavasius quadrangle exactly. Now, why we are trying to do an endonasal endoscopic approach now? Because the natural trajectory of the invasive pituitary tumors, which are the most common tumors to invade the different compartments of the cavernous sinus, they have a natural trajectory to go from the sella or the central part laterally. So it's a mediolateral natural trajectory for the invasive pituitary tumors, and you have significant advances in understanding of the surgical anatomy via an endonasal perspective. and the technique which allows us direct access into the cavernous sinus using an anterior to posterior and a medial to lateral trajectory. Now, the cranial nerves are encountered in the intranasal endoscopic approach. What happens in an open approach is what we fear is the injury to the cranial nerves, because we try to reach and attack the lesions in the cavernous sinus through the lateral aspect of the cavernous sinus, which is formed on its lateral wall by the different cranial nerves. So the corridors are between the cranial nerves, hence filling with these nerves and the spaces may lead to different sorts of cranial pathologies, which leads to significant mortality and significant morbidity for the patient. So in this trajectory, right, when we go through the intranasal endoscopic approach, the medial to lateral approach, the cranial nerves are encountered at the end of the tumor removal. Hence, injuring them is less likely, and it also avoids the temporal lobe retraction and contusion. Now, when do we go for an extended endoscopic approach to cavernous sinus? So these are essentially the criteria for that. Probably a histological diagnosis for the lesions other than the pituitary adenomas, the chondromas and chondrosarcomas, endocrine cure for functional adenomas, cytoreduction in preparation for radiosurgery or adjuvant therapies, symptomatic improvements in patients affected by cavernous sinus syndromes. Now, it's all about dissecting the cavernous carotid artery segment by segment, ligament by ligament, and compartment by compartment. Now, the endonasal perspective is understanding the paracellular ICA anatomy is very crucial, and that is the most important step before we try and go for an endonasal approach. So the paracellular ICA is formed by the cavernous and the paraclinoidal ICA segments. The subsegments of cavernous ICA from the proximal to distal include, as you can see in this diagram, the short vertical segment, which is a continuation of the paraclival ICA. This is a short vertical segment in the posterior compartment that continues as a horizontal segment, and that continues, which has got a posterior genu in between. So this is a short vertical segment, this is a posterior genu, and this is a horizontal segment, this is the anterior genu, and there you have the proximal dural ring here, and from there it takes up to form the paraclinoidal segment and the distal dural ring, and it forms this continues as a supraclinoidal segment. Now, paraclinoidal ICA is a continuation of anterior genu of cavernous ICA. It is located within the clinoidal space here, within the clinoidal space at the roof of the cavernous sinus, limited by the proximal and distal dural rings, as we have been discussing now, bounded superlaterally by the lateral opticocarotid recess or the optic strut here. So this is again another important key bony landmark there. Now we have the middle clinoids. When present, it marks the transition between the cavernous and the paraclinoidal segments. And you also have the middle opticocarotid recess here, just at the lateral aspect of the tuberculum sella here. And this is also important so that because it forms the junction between the paraclinoidal and the supraclinoidal ICA at the distal ring level. So this is a view from the sagittal aspect. This is a view when you're standing inside the cavernous sinus and is looking to the medial aspect of the left cavernous sinus. You're inside the cavernous sinus, you're looking onto the left side of the cavernous sinus from inside medial to lateral view. So this is a practical and surgical relevant endonasal classification we have. As I was saying, this short vertical segment here, the posterior genu, this is a horizontal segment, this is anterior genu, this is a distal ring, this will be here, it will be the proximal ring, and then it continues into the supraclinoidal segment. Again, the different, here you have the corresponding radiological view, the MRI view here. As you can see here in the sagittal section, this is a horizontal segment. Above the anterior genu and the horizontal segment, you have the superior compartment. Below the horizontal segment, you have the inferior compartment, and lateral to that, you have the lateral compartment. So this, on the coronal section, this will be the superior compartment, and lateral to that, this will be the superior compartment, this will be the inferior compartment, and lateral to that, you will have the lateral compartment. And this is the posterior compartment behind the short vertical segment of the ICA, the cavernous ICA. Now these are, let me just rush through these because of the interest of time, because this is a superior compartment. You have the paraclinoidal ICA and the clinoidal triangle there, the oculomotor nerve in the oculomotor triangle along the lateral wall, and the interclinoidal ligament separates the oculomotor triangle from the clinoidal triangle here. This is the superior compartment. This is the interclinoidal triangle. You have the oculomotor triangle here on the lateral aspect. Because the carotid is pushed medially to show us the laterally to show us the oculomotor triangle here, and this will be the region of clinodal triangle. This is the posterior compartment. The most important structure in the posterior compartment will be the meningiohypophyseal trunk, which arises from the genu of the posterior short vertical segment of this posterior compartment. The abducens nerve sits at the confluence. Here, this is abducens nerve, which is called as the interdural segment. The interdural segment, and it is formed in the Gulfar part. The Gulfar part means it's a confluence. It's formed in the part of the confluence of the basilar sinus, the superior petrosal sinus, and the inferior petrosal sinus. So this is the short segment, the interdural segment of the abducens nerve, where it enters the posterior compartment. It is just lateral to the carotid artery, and it is very intimately and very closely associated with the carotid artery. Just between them, they have the sympathetic plexus of nerves, which arises from the ICA. So when you have an excessive packing to control venous bleed in this posterior compartment, it can result in a permanent sixth nerve palsy or an abducens nerve palsy. Now, how do you identify the sixth nerve? You have a short vertical segment of the vertical ICA, which is very close by, and an electrostimulation of the nerve. These are the ways by which you can identify. Now, this is the inferior compartment. As you can see, this is the cellular part. This is the medial wall. This is the ICA that is being seen here. And this is the horizontal. This will be the region of the horizontal segment. And whatever comes below the horizontal segment is called as inferior compartment of the cavernous sinus. Now, what do you have there? You have the sympathetic nerve plexus around the ICA and the distal cavernous segment again of the sixth nerve. For that, you need a transpterygoid supravian approach to reach the inferior compartment. Now, the lateral compartment is formed by the different cranial nerves that form the lateral part of the that are embedded in the lateral wall of the cavernous sinus. They are the third, fourth, and ophthalmic division of the trigeminal nerves. Also, you have the branches of the introlateral trunk that arises from the horizontal segment, or that goes into the lateral compartment of the ICA. An important structure here is optic strut, which forms the upper limit, and the maxillary strut, the lower limit. Again, you require a transpterygoid corridor because of the, and you have a higher risk to cranial nerve injuries because obviously you are dealing with the lateral compartment. Now, there is a medial wall because in the initial times or from the earlier times, we have been taught that there was a doubtful medial wall, and the medial wall of the cavernous sinus is, of course, the same as the capsule of the pituitary gland. Now, the endonasal dissections have brought us to a reality where you can see that the pituitary capsule is completely different from a dural part of the middle or the middle wall of the cavernous sinus, because it forms a lateral boundary of the hypophyseal fossa. It separates the pituitary gland from the cavernous segment of the ICA and venous channels, and the middle wall of the cavernous sinus and the pituitary capsule are separate, defined structures now. Now, what separates the pituitary gland and what attaches the pituitary gland to the medial wall, are the pituitary ligaments, and what separates the medial wall from the lateral wall of the cavernous sinus are the paracellular ligaments. Now, paracellular ligaments, they anchor the medial wall of the cavernous sinus to its anterior and lateral walls of the ICA, the interclinal ligament and anticlinal process. Now, what is most important are these ligaments, especially the carotidoclinoid ligament, the superior paracellular ligaments, the inferior paracellular, and the posterior paracellular ligaments, because resection allows to safely mobilize the medial wall of these ligaments, allows to safely mobilize the medial wall away from the cavernous ICA. Now, these are the cadaveric views of the same. You have the pituitary here. There is a pituitary capsule there, and above that you have the medial wall of the cavernous sinus. And here you see the paracellular ligaments, which are defined: the carotidoclinoid, the paracellular, the inferior paracellular, the posterior paracellular ligaments, which are different in different people, because it is not a fixed structure. They have multiple fibrous bundles that can arise together or separately, and they have been studied in detail in different studies. Now, as you can see here, these were the pituitary ligaments, which are the loose connective tissue that attaches between the pituitary gland or the capsule and the medial wall here. Now, the paracellular ligaments are completely different from the pituitary ligaments, which are loose, flimsy tissues. The paracellular ligaments basically are tough dural folds which attach the lateral wall, the medial wall of the cavernous sinus to the the lateral wall, or to the anterior wall of the cavernous sinus, to the lateral wall of the cavernous sinus, to the paraclinoidal ICA, and to the posterior wall or the inferior wall. And now this is another pictorial representation of the same as I was saying. From the from the medial wall of the cavernous sinus, you have the different paracellular ligaments that are defined now. This is the most important and the strongest ligament is seen in 97% of the patients of the subjects where there is a keratocondylar ligament which can arise as multiple different folds, maybe from the middle clinoidal process, from the superior wall of the medial wall, superior aspect of the medial wall. It loops around the paraclinoidal segment of the cavernous paraclinoidal ICA and attaches to the anterior clinoidal segment. So only if you cut down these ligaments, you will be able to mobilize the carotid arteries laterally while you try to resect the medial wall here, and then come down, or when you try to approach anything that invades the posterior clinoid or to the posterior fossa. So that is the importance of keratocondylar ligaments and the paraclinoid ligaments. So again, these are the other cadaveric views, which gives us a very good interpretation of the same. Again, the different views. Again, this is a short vertical segment. This is a posterior genu. This is again the endonasal perspective of the keratocondylar ligament there, and the superior paracella ligament there. Again, this is the coronal view. This is the endonasal view, which is a pictorial representation where you have an inferior paracella ligament, which can be confused with the inferior hypophyseal artery here, which arises from the meningohypophyseal trunk in the posterior vertical segment. We have to identify specifically while you go about in an endonasal approach between the inferior paracella ligament and the inferior hypophyseal artery. When you try and mobilize the middle wall and go to the posterior compartment or the inferior compartment there, because there can be torrential bleeding or can later lead on to a keratocondylar fistula due to the inadvertent snapping of this inferior hypophyseal artery. And this is the real live pictures while you go for the endonasal aspect. These are another different views where they have purely, these are not our video, this is not our pictures, but the pictures from the journal by Professor Juan Miranda Fernandez, who have done some phenomenal and seminal work in dissecting out these paracella ligaments and the medial wall of the cavernous sinus via an endonasal perspective. Some really good work through which we can all take these surgeries to a different level. Now, endonasal now what in a nutshell, this is about going from the medial to lateral trajectory about the carotids instead of coming laterally in between the cranial nerves. It acts as the cranial nerves whose anterior and medial walls, whereas in the transcranial route they come from the superior and the lateral walls. The superior and posterior compartments, for the superior and posterior compartments to be approached, we need a routine wide sphenoidotomy as we do for a pituitary tumor, and a posterior ethmoidectomy. That is a routine approach, the routine endonasal bone work we do for a large pituitary tumor. But whereas for the inferior and lateral compartments, we require a more lateral extended endonasal skull base approach, which includes a transpterygoid corridor. You have to drill down the uncinate process. We have to do a middle maxillectomy when we expose the posterior wall of the maxillary sinus. You have to drill down the posterior wall of the maxillary sinus. Then you reach the pterygopalatine fossa. You have to lateralize the contents of pterygopalatine fossa. You see the pterygoid tubercle and the pterygoid plates there. You have to drill down the pterygoid plates so that you reach. You also see the Vidian nerve there. You have to drill the inferior 180 degree of the Vidian nerve so as to reach the foramen lacerum also, so that you can reach the foramen lacerum too. So the medial wall mobilization definitely helps for the complete endocrinological cure of functional adenomas by resection of involved medial wall beyond the level of tumor invasion. So intradural pituitary transmission technique, which is also described early to reach the prominent posterior clinoids, is by cutting the keratocondylar ligament, which is the key and the surgical step there. So we need to identify this keratocondylar ligament. We need to learn the surgical anatomy before we attempt any of this. It also provides an access to the posterior wall of the cavernous sinus, the oculomotor triangle dura, the lateral interpedunculair cistern in the selective chondroid lesions, retroclavial meningiomas, and retroclavial epidermoid tumors. This is why we need to understand the anatomy of the medial wall and how to resect the medial wall so as to mobilize the medial wall laterally, and so as to cut the paracellular ligaments there and mobilize the carotid arteries so that we can approach the different compartments of the cavernous tumor when you need to attack the tumors. So these are the key landmarks, which are again discussed. This is Professor Juan Carlos Miranda of the Stanford, from the Stanford Institute. So he has described all these spaces from his landmark studies. So this is again another triangle called as a Miranda triangle, where, like I was telling, after drilling the pterygoids, you will find the Vidian nerve here. You have the pterygosphenoid fissure there, and this triangle will lead you Just behind you have the region of the foramen lacerum here, and you need to drill around the foramen lacerum to get a proximal control, and also to address the lesions that come from behind, from the posterior aspect of the cavernous sinus into the cavernous sinus there. Now, this is a petrous process of the PPS, or it is called as a petrous pause of the sphenoid bone, medially at the middle lateralmost aspect of the dorsum sella, and this is the middle aspect of the Meckel's cave or the petrous apex. And between this you will have, the globus ligament or the petrosphenoid ligament, below which you will have the abducens nerve passing into the cavernous sinus. So the superior compartment, the key landmark is a clinoidal space. The inferior compartment, you need to know the anatomy, how to reach the foramen lacerum by drilling the pterygoid plates and drilling through the Miranda triangle. The posterior part, again, the petrosal process. This is the key landmark there, body landmark there. And the lateral compartment is a maxillary strut between the maxillary division of the nerve and the ophthalmic division of the nerve. And this was one of our cases where obviously you have the cellular tumor, which is extending superiorly and to the different compartments of the cavernous sinus. The inferior, the superior compartments of the cavernous sinus, as I have described, as what has been told, has been invaded here. So this was a short video here. So this was after after the right sphenoidectomy and the posterior ethmoidectomy. This is posterior ethmoidectomy. We have a standard open cellular opening here, and this you see here is the cavernous carotid, the horizontal segment, as we are moving through to try and attack the tumor and take out as much of the tumor as possible from this different compartments of the cavernous sinus. This brisk venous blade which we are seeing is from the anterior wall of the cavernous sinus, which we have cut inferiorly here, and then we are entering the cavernous sinus, the superior compartment there. So this is the cavernous ICA, as we exactly where the suction tip is here. This is the superior wall of the cavernous sinus in the superior compartment. So this is the interclinoidal ligament probably, and this also serves as an important landmark between the paraclinoidal and the distal aspect of the paraclinoidal ICA. This is the wall there. This is this probably is interclinoidal ligament there. So these were snapshots which are taken in between tumor dissections. In a few of our cases, we have on the right side, the right ICA, the posterior aspect of the short vertical segment in the posterior compartment, where you have the right inferior hypophyseal artery, which is very important to be dissected out and cut, so that you don't confuse that with a different segment. Of course, you require a Doppler carotid probe for this before you try and attempt to cut or dissect or resect these small vessels. Insignificant vessels, we can definitely we can afford to cut and section this right inferior, the inferior hypophyseal artery here. Again, this on the left inferior hypophyseal artery in the left posterior compartment there. Now, this was another case which we had where you can see the tumor has invaded the superior compartment here and the lateral wall compartment there. This was a case of pituitary apoplexy, which came with multiple cranial calces with an ophthalmoplegia. And after the section, she had a near complete recovery of the cranial nerves, as you can see in the contrast, as well as the T2 studies, almost totally the tumor was removed. Now, the endoscopic transocular motor triangle approach, we have the pituitary adenomas that extend into the parapedunclar space by invading through. This is another advancement of the endoscopic approach, where you have the endoscopic transocular motor triangle approach. That is, you are trying to approach through the superior. First of all, you try to resect out the medial wall of the cavernous sinus. You enter the superior wall of the cavernous sinus by chasing tumor in the superior wall, and then the tumor helps us to go beyond the superior wall of the cavernous sinus, lateral or medial to the oculomotor nerve, into the superior space, beyond the paraclinoidal ICA, into the parapeduncular, as well as the space which is medial to the uncus. So these are usually pituitary adenomas that extend to the parapeduncular space by invading through the roof of cavernous sinus. The interclinoidal ligament is the key landmark here, and the oculomotor nerve and the posterior communicating artery needs to be identified early with electrostimulation and the Doppler probe. This is the artistic representation of the same. You have this is a superior view of the same, where you have the cavernous. This is a pituitary tumor. This is a normal pituitary. This is a pituitary tumor that has involved the cella coming into the supracellular compartment, invading the superior compartment of the cavernous sinus there. It has pierced through the wall of the superior or the roof of the superior compartment into the parapeduncular space here. This is the cerebral peduncle here, or the cerebral crus here. It has involved and invaded into the parapeduncular space here, medial to the uncus here. These are again the cadaveric dissections which will help us to know the anatomy, how to deal with these tumors. This, as I was talking about, is the oculomotor triangle, which is bounded medially by the interclinoid ligament between the anterior clinoids here and the posterior clinoid here. This is the anterior petroclinoidal ligament. This is the posterior petroclinoidal ligament. This forms the lateral aspect of the roof of cavernous sinus, through which the oculomotor nerve will come from the posterior fossa into the and comes into the cavernous sinus through the roof here. This is a video which MRI which shows the tumor which is rising from the sella into the superior compartment and is extending into the medial side of the uncus and also into the parapeduncular space here. Again, this Professor Miranda has done again some beautiful work here to help us understand how to deal with these tumors by going through the transoculomotor triangle there, which I was describing there. So again, this is the inferior compartment beneath the horizontal segment, and this is a superior compartment there. And as you can see here, this is the interclinoid ligament there. This is a cranial nerve 3, which is lateral to the interclinoid ligament there. What we try to do is you resect the middle wall here, and then you chase the tumor into the superior wall here, and you identify the interclinoid ligament there, and you also identify the cranial nerve 3 there by using electrostimulation, and then you try and mobilize and chase the tumor through the oculomotor triangle into the parapeduncular space there. And these are the structures which will encounter there after resection of the superior wall. Now, these are the essential accompaniments that we all require while trying to do this expanded endonasal approach. You need a dynamic endoscopic team, which is always formed by the neurosurgeon and the ENT skull-base surgeon, because you need a nasal approach and a care, even preoperative and postoperative care, and an extensive nasal care is required. You need a superior operability for the superior operability you require this team, and for the multilayer reconstruction, because skull-base reconstruction after your surgery or surgical removal of the tumor is the third and the most important aspect of all these techniques while we approach these tumors endonasally, because otherwise you can end up in a massive series of leak through that. You can ultimately end up in a morbidity and mortality because of meningitis. Obviously, you need a 0, 30, 45, and 70 degrees rod lens scopes. We need a right angle dissecting knives with a blunt tip, is the Misuho one or the McElveen one. You need a carotid Doppler microprobe. You need neuro navigation. You need intraoperative nerve monitoring. You need effective hemostatic agents in the form of surgery flow or flow seal. You should be having ideally an endovascular team standby because you never know. So the take-home message is basically an endoscopic approach can provide excellent access to these tumors involved in the cavernous sinus. It is a different perspective. So we need to understand the carotid artery anatomy, which is the key and the most important aspect, the involvement of the carotid artery and how to control the carotid artery by knowing the carotid artery anatomy. It is a key to the endoscopic approach. And definitely there is a significant learning curve for these coronal plane approaches. And these are my references, the Rotten's textbook of anatomy, the Schmidt and Speed, our operative Bible, the Neurosurgical Atlas from Professor Goodall. And these were the seminal papers which have come out over the last 4 to 5 years from these great phenomenal surgeons, Joanne C. Miranda from the Stanford, and Carl Snyderman and Paul Gardner from Pittsburgh Institutes. So these are the different papers which I have referred to. Our experience is limited, but definitely we have been trying to grow in this approach by defining this surgical anatomy and by defining these paracellular ligaments, by defining how to dissect out these medial sinus walls, and being a very dynamic skull-base team. Thank you, George, sir. Thank you. Thank you all.
Thank you very much, Bobby. That was an absolutely brilliant presentation. And I think your patience and energy at the end of a very tiring day, it was really, really very exemplary. I'm not sure if there is energy left for questions, but I'm sure we might have a few points that Prakash and Dr. Ayyadurai perhaps would like to discuss. And the floor is open for questions and discussions.
Bobby, very nice talk about the various anatomical concepts, and I think all these papers are extremely important because they have really changed the way that we look at the cavernous sinus from the endonasal aspect. We had the Hakuba, Dolenk, Kawase studies of peeling the cavernous sinus from the lateral aspect. But this shows how the medial wall of the cavernous sinus can be accessed to approach the medial compartment. The only thing that I would like to add is the safety of surgical approaches for tumors that extend beyond the carotid artery when we go from medial to lateral. In the medial compartment, most of the nerves are not directly in contact with the tumor itself. The nerves lie in the lateral compartment, lateral to the carotid artery, except at the posterior part. And whenever tumors enter into the lateral compartment, especially for pituitary adenomas, it's probably not prudent to approach them through the nasal aspect because these nerves are not protected by arachnoid. And if there is a extraocular nerve injury, either to the third or the sixth nerve, especially to the third nerve, the consequences are devastating because the patient has ptosis, and the main aim of surgery itself is to give visual improvement. So, as far as the middle compartment of the cavernous sinus is concerned, the endonasal perspective gives a very direct access to the medial, the posterior, and the anterior-inferior compartments. And as far as the lateral compartment is concerned, even though it is accessible, sometimes it may be better not to go there.
Exactly, exactly. Totally agree, sir.
I
Totally
agree
agree.
here.
Thank you, Prakash, for sharing that perspective from your vast volume of experience.
This is Ayyadurai. Dr. George, hear me?
Yes, Dr. Ayyadurai, welcome, and we are very happy to have you.
Thank you. So it was a nice presentation, Dr. Iype, very good description of the anatomy. We don't have to go through the articles again. Every time, whenever we go for an coronal approach, I pull up this article and then go through this both the articles every time before going into any cases in the coronal approaches. I totally agree with Prakash in tumors extending beyond ICA. Leave alone that. Going to the Dr. Iype also said you have to, the learning curve is pretty steep. Most important thing is we have to get trained in the cadaver lab before venturing into a patient. So that's what I just want to convey. Anyway, it was a nice presentation. Thank you.
Thank you very much, Dr. Ayyadurai. Bobby, tremendous energy at the end of a very tiring day, and I really admire it. And I'm sure that each and every point that you stressed upon is recorded for posterity, and all the talks here we have had here will be there with us for the rest of our lives when we put it up on YouTube. And I'm sure the residents can go back to each of these slides, rerun the presentation, and soak in all the information and the wisdom that has been conveyed in each of the talks, and especially the cavernous sinus anatomy. For a few last words of wisdom from Dr. Ajith. Ajith sir, may I invite you, please?
Yeah, it's a very wonderful event because it's a collage of many topics that is interesting to all of people in a real virtual world. We are going in a virtual world, and gradually, I think this is going to be the final answer to COVID that will be stay here for another 3-4 years. So that's the beauty of this. We can approach it from our working place anywhere, wherever you are approach from the this feast of good topics. And so thank you, George. You are the sole person. You are the soul of our all activities. So
most welcome, sir.
Once again, congratulate you for efforts to make it more lively and lively.
Thank you, George. Thank you. Thank you for the opportunity. Thank you all.
Thank you very much. We've been able to reach out to many others who would not have been with us from other cities. And what was heartening today is that today when I went to work, my resident who was on duty today said that Thankfully, I can also attend despite being on duty. If we had a physical meeting, perhaps we would not have had people from the operating room attending, and that was what made this evening very special. I especially thank our mentors for today, Dr. Ajith and Dr. Shafeeque, for all the pains and the efforts. And most importantly, you have broken the stereotype that only people in academic institutes are academic. You have raised the academics and the surgical technique to a absolutely new level. And I'm sure that many others will catch up with this later on with our YouTube presentation. I know many who don't attend here, but then later on they see it and they always put in a kind word and say that we have caught up with it later. So this will be there with us recorded for posterity. And I personally thank each and every one of you. If anybody wants to add a last point or just a discussion, I will be very happy to hear that. And I specifically thank many of our senior faculty, Professor Krishnamar, Dr. Sunil, Dr. Thomas Varghese, many who were there just for a short while, many from other cities as well. Thank you very much for your presence. And I request maybe Bobby or Ajith sir for the last final word before we say good night.
Yeah, it's about. Bobby, please tell the.
No. I was requesting Ajith sir to please convey the thanks.
Actually, when George put an idea of this sort of virtual meetings, I thought it is the best way to convey our ideas and then share our ideas, because it's a very simple that you can anybody can present it from anywhere if you have an internet access and a mobile phone, and anybody can ask, and it's a very versatile way of presenting. I find that real meetings, the physical meetings, will cease to end when these sort of meetings will become more and more common. So I once again I thank everybody who attended the meeting, and I also thank George Villannilam for his and Dr. Thomas Iype sir for giving us this opportunity. We present this on behalf of the Cosmopolitan Hospital, and his idea of presenting these cases every month from each hospital is wonderful, and we hope that we can have a good format in that way of presentation in the coming events, because I don't think for the next few months we were not able to do a physical meeting. So once again, thanks to all who participated, and thanks to George for his excellent organization.
Sir, may I also put a note on our very, very fantastic neurological colleagues who have taken all the pains in spite of their busy schedules, and then come out with very fantastic presentations. Dr. Rosemary, Malini Madam, even Shafeeque sir is around. Shafeeque sir was around in between, so he was guiding us. So it was it's a great team actually. It's a great team. Thank you.
Thank
you.
I think Shafeeque is around. I request Shafeeque to say a few words. Is he around?
I'm not sure, sir. I think Shafeeque sir is. I'm not really sure. I think Shafeeque sir is not there now. But Rose is there. Dr. Rosemary is there. I think Malini Madam is also probably. Yeah, Malini Madam is there. Yeah. Malini Madam is here. Dr. Malini is here. Malini Madam, please.
Yeah. Can you hear me?
Yes,
yes, ma'am.
Yeah, just like Ajith sir told, we would like to thank Dr. George for this opportunity, and the meeting has come out better than any of us has expected. And the neurosurgery presentation was also very good. Thank you, Ajith sir, and thanks, Rosemary. I personally thank Shafeeque sir also for his contributions, and Robert sir has agreed without any coaxing for this presentation. So I personally would like to thank all on behalf of Cosmo team.
Thank you.
Thank you, Dr. George.
Thank you so much. We will be sharing an e-certificate and a small e-book with you in the few days to come, and also the YouTube video, which will be there as an enduring record and in our memories for many more years to come. We'll remember this evening for the rest of our lives. Thank you very much, and it's good night on behalf of everybody.
We will go for a e-dinner.
I'm sure many of you would have already caught up with dinner perhaps during the presentation. That is also one of the advantages of having a meeting like this. We hope that such teams will come forward from all the other hospitals in Trivandrum. And we are sincerely hoping that the PRS hospital team will do it next month. Let's see how we can get our act together. And the earliest when it is possible, I know that there is a screen between us, however close that we may appear to each other. So hopefully in the days to come, in the months to come, we'll be able to take away that screen and shake our hands and have a physical meeting because nothing can perhaps make up for it. And on behalf of the Neuro Club, let me thank each and every one of you, both the speakers, our chairs for the day, and our guests from outside. Thank you very much. And let us log off. Good night. And till we meet again. Bye.
Thank you.
Thank you.